हेलो, नमस्ते, बताइए। हाँ जी, आज तो छुट्टी है।
Dr. Shruti, good evening. Dr. Vasanti, good evening. Jayesh sir, good evening.
Good evening.
Pawan sir, good evening.
Good evening. Good evening. You want me to change the place somewhere? कितना light ठीक है?
Some light आ जाए तो अच्छा रहेगा।
ये better है?
हाँ, बट आपके ग्लासेस ज्यादा शाइन कर रहे हैं।
अभी?
हाँ, अभी ठीक है। हाँ, अभी ठीक है।
मैंने सर को ऊपर नहीं करके देखा, नीचे करके देखना होगा।
Hello, everyone.
Hello, good evening.
Good morning from here, actually.
Good afternoon. This is Rajesh Sharan from Shillong.
Good evening, Rajesh sir.
Good evening, Dr. Sharan.
अभी still it is good afternoon, sir. Good afternoon till for the next 3 minutes, and then it will become good evening. And at UK it is
Good morning.
good morning. Sir,
I was
so
just
nice to
thinking-
see you from Shillong.
Yeah, Shillong is different. It's not so warm as you have in the rest of the country, so it's a different weather here.
It must be quite pleasant there. Here it is so hot.
Yeah, this is very pleasant, and it's of course rains all the time. I think in Delhi, Dr. Gupta, you are in Delhi, so it's preparing to receive some rain from this evening, I understand, and next few days, I guess.
Yeah, it is raining here. Malab just started.
Good for Delhi. But from next year, I will be in your mess, and I will be in the same weather.
Yeah. You will be here in Delhi for.
Yeah. So we still have few minutes.
Yeah, 2 minutes.
I guess.
So we have got around 41 people have joined. I am sure there will be more people joining in.
Yes.
And people keep joining. Jay sir, good evening.
और नमस्ते, कैसे हो बच्चे?
सर ठीक है, बिल्कुल आपका आशीर्वाद है सर।
बहुत भगवान बहुत अच्छा कर रहा है काम। हाँ,
Thank you so much, sir. Thank you.
It's great to see Rishabh after almost 3 years.
Yes, sir.
I think last we met at IIT Gandhinagar.
Yes, sir. Yes, sir.
And I can see a lot of beautiful women right from UK to India to Ceylon.
Shillong, I don't know. If you see me as a woman, of course, it's different.
There might be many more. Sir, you might have invited some.
Yeah, but I see a very known face for me, very dear face, Dr. Pooja Patwardhan here from UK.
Hello, Rajeshji. How are you?
I'm good. Good to see you. I was looking forward to, and I think Pawan gets a lot of credit for, it's a Herculean task to pull off this kind of show. Absolutely. Of 4 days, 4 events in a month and on a Sunday, and still get a sizable number of people joining. I was amazed at the number of registered participants that I saw somewhere in the WhatsApp chat.
1242, sir.
Yes. No, I thought something like 1100 plus.
That's right.
Now it is, in the morning it was 1100, sir. Now it is 1242.
Oh, 1200. Wonderful.
Oh, that's
so
great.
Compliments. I think it's
That's
a
very
lot
good.
of work. Lot of work, yeah. And I think it's needed in the country, and particularly in this domain of tobacco. And everyone has to join hands and work hard to make something happen, because I live in the Northeast for very long, and this has tobacco burden which far exceeds the national average in every aspect.
Yes, yes.
And so the health consequences, and so the human suffering. So it's phenomenal.
Rishabh, can you send me the background?
Yeah, I'll just put that on the.
Good evening, Dr. Patwardhan. Good evening, Nandita.
WhatsApp.
Good evening.
Good morning.
Good evening.
Good evening, Dr. Pooja. And good evening, Dr. Sharan and everybody else. Good evening, Pooja. Dr. Patel, Garima.
Hello.
Yeah, ma'am.
And so many other
Hi,
participants have
everybody.
joined in. I can see Durga Acharya, our regular participant. Anand
Hello,
Divekar
sir.
is also here. Huh? Hi, Pooja.
Hello, sir. You just called me, sir.
Yeah. I just said hello to you.
Hello, sir. Good evening.
Yes, Pawan, I'm there. Yes.
Hi.
This is Anand Divekar. Yeah.
Yeah. Hi. I'm sure Nandita is so happy to see you here.
He always attends all my webinars.
Okay.
He's a very
Okay, that's
sincere
great, that's
husband
great.
to encourage.
Yeah. I wish our wives were also like that sincere. Na? They would attend our seminar. It doesn't happen with the wives.
He's actually taking a good part,
Okay,
and he's
I
an
think-
orthopedic surgeon. That's good. Let's talk. Yeah.
Yeah, I think it is just 403. Dr. Sandeep, namaskar.
Yeah,
Welcome.
namaskar. Thank you very much.
And Dr. Shruti is also here. Dr. Shruti, hi. Namaskar. I think we will start, Rishabh. It's
Okay.
403. Yeah. Dimesh sir has also joined. Just let's start. Sir.
Rajesh ji.
Good evening, sir. Wonderful to see you,
badhiya.
and I was just complimenting Pawan, but I think you are part of that, and the entire team that has worked so hard.
Pawan and team.
Yes,
Great, yeah.
I think so.
So, with the permissions of the organizers, we begin the third day. So, on behalf of the entire team of ICanCaRe, IHBAS and Gujarat University, I welcome each and every one of you to the third day of the International E-Conclave on Tobacco Cessation, themed with the use of pharmacotherapy for effective implementation of tobacco cessation policies in the country. So I welcome each and every one of you, the viewers who are listening to us on Facebook Live and YouTube Live as well as who have participated and joined us live on the Zoom in this current Zoom platform. So I would like to also welcome our Chief Patron, Rotarian Kalyan Banerjee, our Patron Professor MC Mishra, Chairperson Professor Dr. Nimesh Desai, and our Co-Chairperson Dr. Rakesh Rawal from Gujarat University. I also like to welcome the entire organizing committee who have made this particular event, which a month-long event, divided into four sessions to be a fruitful event for effective implementation of tobacco cessation. I would also like to thank our supporters with whose help we could materialize this and make it a reality, make this event a reality. I would like to thank ISO FHNO, Indian Chess Society, Delhi Psychiatry Society, CMHARTS, RAGAP, RSD Hospital, and IDS and Santosh University. I would also extend my gratitude to the pharma partners who have been consistently pushing this particular need and making people to adapt this product so that effective tobacco cessations can be made available to the public. So I extend my gratitude to pharma partners Ruzan for Tobacco Nil and JB Chemicals Private Limited for Nosmog, that's nicotine lozenges, and ICanCaRe for the Triscare, that is the mouth opening devices. A few of the glimpses for the past few week events that we had. We had various prolific and educated and learned speakers to deliver us on the insights about various aspects of tobacco cessations and how it can help us in how it can help people in overcoming this habit and making the tobacco-free India dream to be a reality. So we move towards that part. With this, I would also like to put forth that this particular webinar is being monitored, and any unsocial events are being recorded and will be dealt with the cyber laws of the country. For this, I would request each of the participants to please keep your microphones on mute. And if you have any questions, just raise your hand and the moderators will get back to you. And you can also put forth your questions on the chat box so that those questions can be taken up at the end by the panelists, and your questions can be answered. So with this, we move ahead with the scientific session. So I hand over the dais to our Master of Ceremony, Dr. Nandita Divekar. Dr. Nandita Divekar is a consultant in anesthesia and critical care at Medway NHS Trust in UK. And she's the leader there for smoking cessation in her hospital. And she's very passionate about tobacco cessation, mostly smoking cessation, and has been pivotal in starting the stop before the OP clinics. And she has also been awarded for the CO award for the brilliance to study the Ottawa model. So I welcome Dr. Nandita Divekar to take this scientific session forward.
Namaste and thank you very much. Good morning, good afternoon, and it's good morning. It's a very beautiful morning here in the UK. And thank you very much, Dr. Pawan Gupta, Dr. Reena, and Dr. Nimesh, sir, for allowing me to moderate this session. I'll be on introducing the chair people, and the chair people will take the session forwards and give their remarks at the end. Let me first introduce Dr. Jayesh Patel. Dr. Pawan Gupta has mentioned him as his mentor and teacher for MCH. He's been a teacher for more than a decade. And he is also the director of Apollo CBCC for 11 years. He has been very actively involved in the cancer awareness campaign, Chaitanya Abhiyan, for 22 years. Welcome, Dr. Jayesh Patel, and the podium is yours.
Thank you, ma'am. Today I feel so happy, to see Pawan, who joined us before 25 years as a fellow in surgical oncology. He decided to get the career as an MCH, and he joined us, and he was a wonderful surgeon, believe me. But surgeons are passionate about doing surgeries. But he's a guy who is different, We are taught to treat the patient. We are taught to prevent the disease. But most of us, they don't practice for prevention. Here is a gentleman called Dr. Pawan Gupta, a very senior consultant now at Delhi. And he has by option selected to work for de-addiction or de-addiction about tobacco. He started his NGO called ICanCaRe. Now, I will request Dr. Pawan Gupta to deliver his session today, importance of treating the tobacco de-addiction. I will request Dr. Pawan Gupta to take the podium.
Thank you so much, sir. And it was a pleasure, and it gives me even more honor that I am talking in front of my teacher, who handheld me so that I can do my best in my surgical career. And I learned a lot from him. But today it's a little different thing that I'm talking about. So it is basically on something like how do we change the multi-modal approach for tobacco cessation. In the last 2 days that we had about the pharmacotherapy, we had about the NRT, but how to get everything together. So this is what I am talking about, the non-pharmacological aids, how we can be incorporated so that we can take this forward. So when we are talking about the multi-modal approach, normally all our clinicians have it very thought to have a telescopic view, like specifically the specialists, the oncologists, the cardiologists, they are specifically focused on their area only. And that is where the problem starts. But as we see in oncology practice also, it is basically we have to see the patient as a whole. A complete view has to be given, and that is where we need to work on. And just look at the tobacco scenario that we have in India. The new entrants per year, that means number of new tobacco users per year is 22 lakhs. That's a phenomenal figure. And that's per year is around 13 lakhs just because of tobacco use. So every year there is an increase in almost like 9 lakhs of people joining this group or becoming prevalent in this tobacco habit. So the number of quitters is just in thousands. Just jisko bolte chiller, in a very dismal figure, very small amount. So how do we work on this? This is something that is important, and that is where we are working. So we need to induct doctors of all specialty to work for this, whether it is a cardiologist, pulmonologist, dental, oncologist. Of course, psychiatrists and psychologists are supposed to be working in this area. They are specialized for this. But when all other groups join together, then only we will be able to make a lot of difference. And more than that, we have to implant tobacco marshals. They are the people from the society, create these tobacco marshals and implant them in the society so that they will be talking about tobacco. They will be influencing the people, those who are taking tobacco, and also influencing the people not to start tobacco. How? And more ambassadors like those who have quit tobacco to talk that yes, they can quit tobacco. And this is one very quote that most of the people keep on using it. Mark Twain said, "It is easy to quit. I quit many a times." Well, this is a very clever way why I believe that people have used this. The pharma companies have used it. The tobacco industries have used it to tell to the patients who are taking tobacco that you cannot quit tobacco. It's just impossible for you to quit tobacco. And if you will quit tobacco, you are going to again relapse. But what we need to replace it with the commitment that, yes, I am committed and I have been able to quit. I am a winner. This is what this ambassador, this message should go everywhere. Yes, it is possible to quit. That is what and then the another major problem that this dismal figure is mainly because most of these tobacco cessation centers are actually being manned by unskilled professionals. Those who have just maybe just got some type of some knowledge that tobacco is bad. They start thinking that they are the counselors, and they start. And so this quackery in tobacco cessation is very much another one very important factor why people are not able to quit tobacco, and they start believing strongly that yes, it is not possible to quit. So the self-styled tobacco cessation experts mishandling, which makes a strong case that it is not possible to quit. So this is where we have to work, and that is where this ICanCaRe came in, and here we have shown a success rate of almost 92%. And why is that so? And it was not a one-day journey, it has been a long journey. We kept on experimenting, we kept on researching, we kept on changing, and then we came up with a standardized approach right now, which we are following. And I'm sure the standard that we are following now will change in the future further. So this is where we introduce the ICanCaRe app, where every person can include or can start joining in. So this multimodal approach to this complex disease that gives, that has come up like A, B, C, D of tobacco cessation. That is where I have kept it like A, B, C, D of tobacco cessation. And what is this A, B, C, D? Active motivation and follow-up. Yes, this is the first and the foremost thing that we require for this. This motivation of a person will slow down as we go on. So this has to be, the person needs to be motivated continuously, regularly followed up, so that their motivation and their commitment persists. And this is what it is, like group counseling, morning yoga sessions. This is what we have started every morning. Invariably for the last 3 months, we started this yoga sessions, and it is working wonderfully for our patients. Every day, 6:45 to 8 o'clock, it is there. Then we started with a quit coach and the quit buddies who regularly talk to the patients on a regular way. And then we started this WhatsApp support group that every patient will be allotted a quit buddy, a quit coach, and of course the specialists who will be handling or will be able to answer any queries that they have. And then B stands for behavioral therapy, and that is what we worked on, the 7D intervention. A lot of people talk about the 4D, so we made it a 7D intervention. And here another very important is the stress management, because most of the time the people would say that the stress is the one why they keep on taking tobacco. So this 7D includes drink plenty of water, deep breathing exercise, delay, distract, diet, discuss, and drug. And drug is basically not for the tobacco cessation drugs, but the drugs for the comorbidities that these patients will suffer. So this is where the comorbidity management comes in, the oral screening and prophylaxis, routine examination at the hypertension, diabetes, LFT, chest x-ray, a mouth opener exercises like Transdermal, all these things. These patients who actually are taking tobacco, when they quit tobacco, this other things actually surface out, the nutritional deficiency, the immunity deficiency, the oral pre-malignant lesions, the submucosal fibrosis, the cough, the constipation. These also needs to be addressed in a multimodal approach towards tobacco cessation, because if these are not addressed, then the person is likely to go back into or relapse with tobacco. This is the most important aspect that we have to. And of course, the drugs, that is for the NRT or the non-NRT. I don't have to talk more on this because we already had 2 days of discussion on this. So this is another very important area that we have to take care. So what we made is a balanced approach where we have got the medications, the behavioral interventions, withdrawal symptoms have to be managed, associated illness management has to be there, and then the immunity has to be also taken care, because once these patients who have actually when they stop taking tobacco, many such diseases will come up. So this ICanCaRe digitalized protocol based treatment has to be individualized treatment for each and every person that we take care. So then we introduce something very important, and this is what we call it a Transdermal. That is a very important device for these patients, because in India, smokeless tobacco is so rampant. The patients will have, they are not able to open their mouth. And this is what trismus is a very rampant thing because of submucosal fibrosis, and the only methodology is mechanical mouth opening that is required. So we made this device. This was researched at Gujarat University, where we are incubated, and now it is available across India for our patients, which has helped a lot. And for the smokers, to release the cough, that all that has been deposited in the trachea, to open up the bronchioles, this a cappella instruments comes very handy. So this is something that is required. And what is the current scenario? We are looking for people around. The tobacco cessation specialists are being sought, but they are not available. So this is where people want to quit, and we need to have tobacco cessation specialists across everywhere. And this is what I say, that the 4 pillars of success is availability, scalability, visibility, and networking. That is what is that required, that we need to have lot of peoples, lot of marshals, ambassadors, specialists, and volunteers across the country. And each and every corner, nook and corner, we should have a tobacco cessation, a trained tobacco cessation specialist available who is skilled enough and who is visible to the people by through their networking system, through the system in the hospital, so that they can be easily taken, they can help out. So this is what we are doing, building manpower, making them available, skilled, visible, and networking. So through this multiple ladder step approach, and we are doing this through this ICanCaRe Academy, where we have got accredited by the Gujarat University. And of course, these are some of the self-help resources which is available for the patients to take care, and as well as for the doctors and for the people who want to learn more. So just a simple thing, this Android app is available and it helps people to understand. There are a lot of blog articles, a lot of materials which is there, the withdrawal symptoms, how to take care of the withdrawal symptoms, how to take off the cravings. So all these aspects, just not by the medications, but by various other methods that needs to be done. So we need a lot of happy faces, and that's what we are doing, meeting, going around and training people and taking care. So thank you so much for the ever increasing ICanCaRe community that we see today. Thank you so much. And I hand it over back to the Dr. Nandita, sorry.
Thank you very much, Dr. Pawan. I now hand over to Dr. Patel to give his remarks about your and what he felt about your talk and his advice to us as well.
Yeah, being a surgical oncologist, I have realized that the treating doctors are less in number. They don't have time to talk about de-addiction from alcohol, tobacco. They hardly talk about preventive oncology also. Now, here is a clinician who has highlighted a lot of good things. Now, I would request all my clinician friends to take one oath that at least, they would give one preventive advice to the group of the patient or relative of the patient. So in future, this would create a great positive atmosphere for a preventive disease. Now, what Pawan has narrated is a wonderful thing. It's a comprehensive multimodality approach for de-addiction, and that is a need of time. I might further say that why not, as Mr. Modi ji has started the spiritual teaching, the happiness teaching in schools, why not we start the education about all the side effects of addiction, as well as to the medical student about de-addiction methods, so that future doctors are well empowered to practice preventive medicine as well as preventive de-addictive, the whole scenario of addiction. Because in India, we are growing, but we are growing as a country consuming a lot of tobacco. So instead of, taking number one in diabetes, and now we should not be taking number one in any other diseases. And Pawan, I should congratulate, and I must congratulate you for a wonderful social work you are doing. And God bless you, dear. Thank you, ma'am.
Thank you very much, Dr. Patel. And yes, Dr. Gupta, it's absolutely important for even in UK. We don't have that. We need to teach our junior students as well as medical students. And that's what I'm trying to go next time, saying whether our young doctors can teach their younger juniors as well to go on this path. Thank you very much again. Our next chairperson is Dr. Shruti Srivastava. It gives me great pleasure to introduce her. She is working as a professor of psychiatry in the Department of Psychiatry, University College of Medical Sciences, affiliated with the University of Delhi and Guru Tegh Bahadur Hospital. She has over 80 publications in national and international journals, and she's a reviewer for peer-reviewed journals, and she's associate editor for Psychiatric Journal, and the list goes on and on. She has been working on the proposed amendments of Mental Health Care Act 2017 since 2 years, and she's a convener of Women's Mental Health, IPS. She has co-authored IPS position statement on violence against women. And she is a recipient of the national and international awards and fellowships as well. Welcome, Dr. Shruti, and she's going to chair. Yeah, and she's going to chair the biopsychosocial aspect to tobacco cessation. Welcome.
A very good afternoon. It has been a very interesting and indeed something unique which Dr. Pawan shared. We were not aware of your unique inventions. Otherwise, sir, we would have definitely been used in our clinical practice. And Dr. Patel, I want to tell you that we are already sharing your view on a computer assisted. We've developed a computer assisted de-addiction counseling session for especially for nicotine dependence, and we are training all our undergraduates. Last several years they come to us, they get posted, and we are doing it in undergraduate posting as well as for the interns and for the resident doctors. So that is we've been seeing patients and every day, but the whole thing is that as Dr. Pavan has been highlighting, we need to have ambassadors, and I really appreciate his point of the ambassadors at the grassroots level, because that is where I think we are not able to still get that networking which he has shared. So coming over to Dr. Vishal Chabra, he has over 20 years of experience as in clinical practice, and he has worked in our institution as a senior resident and worked in IHBAS, RIMHANS, and Metro Group of Hospitals. He is a life fellow of Indian Psychiatric Society, Indian Association of Biological Psychiatry, Indian Association of Social Psychiatry, and Indian Association of Private Psychiatry. And he is currently the co-chairman of the Indian Psychiatric Society Task Force. Can you just move on the slide? Okay. So he's a senior consultant, and he has his own clinic as well, as he's attached to several leading hospitals and has a very enriched experience. So we would like to hear our speaker, Dr. Vishal Chabra.
Thank you, Dr. Shruti. Good evening, everyone. I'd like to thank ICanCaRe and IHBAS for organizing this amazing E-Conclave spread over a whole month, taking up Sundays evening, very nice. I already actually did a program with Dr. Pavan and his team in December. There was this course they were doing, so I tried and I worked in that. I think it's very interesting the way they have taken tobacco to a different level, tobacco cessation, because if you look at the rehab centers, they dole out cigarettes to the de-addicts as part of the token economy. So if you have good behavior, you get a cigarette. That's the way things have been going on. So nobody looks at tobacco as a serious, life-threatening problem. So anyways, so I'm very happy with what ICanCaRe is doing. So let's come to my topic, because we have very short time. I wanted to talk about the biopsychosocial aspect of tobacco cessation. Can you see my slide?
Yes, Dr. Vishal, we can see.
Thank you. I'm loading it here. Okay. So I'm going to talk about the biopsychosocial aspect of tobacco cessation. So there are different models of addiction. So सबसे पहला model था, that was the moral model. Moral model put the blame on the patient for getting addicted, and it is their responsibility to get de-addicted. So उनकी responsibility. So if somebody was getting addicted, it is their moral falling down, so and they have to lift up. That was the earliest models of addiction. Then that came the enlightenment model. Then enlightenment model is the one which is used by Alcoholics Anonymous and other groups like Narcotics Anonymous and other similar groups. They talk about that, okay, you got addicted, that is your, that is your fault, you got addicted, but coming out is not your problem. We're going to help you come out. And so you accept that alcohol, you cannot control it, and you give it to supreme power, and that will help you. So that is the enlightenment model. I'm talking very briefly. So if I'm missing some details, please don't mind, because the time is short. Then came the medical or disease model, or biomedical model, which talked about there's a causation and there's an effect, which again talked about, how genes are involved, how biological rhythms are involved, how chemicals are involved, and that was causing the disease. And the focus was on pharmacotherapy and treatments, more biologically oriented. Then came a compensatory model, because there was always the reason these models have been evolving, because of our model was putting a lot of pressure on the patient, making the person feel guilty. The second one was not working out that much, so medical model came in, but medical model its own liking, because there are patients who get better without treatment, and there are patients who don't get better despite all the treatment. So that's why these models are getting involved. So there came a compensatory model. Now this compensatory model looked at various factors which may be causing any kind of addiction. So not exactly biopsycho, but it is kind of precursor to biopsychosocial. So they looked at various factors which could be leading to it. Then came this famous psychiatrist who came up with the biopsychosocial model for mental health problems, mental diseases. And addiction also took note of it. And so there was a biopsychosocial model of addiction. So what is it? So this model talks about addiction is a complex disorder. There's an interplay of host of factors, not just biological factors, but also psychological factors and sociological factors. So yes, somebody may be genetically prone to get addicted, but also depends on the person's personality traits, also depends on the person's upbringing, also depends on the way a person is living, the environment around, the social norms, the customs there, the peer group, the availability of the substance. So multiple factors are involved. The family, the modeling of the parents, all those other factors are also take a role from before somebody becomes an addict. So if you look at biological, addictions happen, the physical addiction. So we know it's biologically oriented. That's why you're having withdrawal symptoms. And that's why you get a relief when you use the substance. You have stress, you use the substance, immediately you get a relief. So there's a chemical thing going on in the brain. We also know there are reward mechanisms in the brain, which have been dealt before in the previous sessions. I will not get into detail. Similarly, psychologically, paired activities. So a lot of times, people, they get up in the morning and they smoke. They say, unless I smoke, I can't poo. So, before they go to the toilet, they have to smoke. They have to smoke after, having a dinner or having a meal. So those kind of paired activities, which also becomes part of routine habits. There are triggers. There's a lunch break, or there's a coffee break in the office, or you're feeling too stressed, then that triggers a nicotine break. They call it nicotine break, or tobacco, lighting up a cigarette or chewing tobacco. Again, meeting in a social gathering leads to that. Coping with emotions. Lot of addicts, they don't know how to cope with stress except taking the help of the crutch of addiction, whether it's alcohol, tobacco, or any other substance. When they're stressed, they'll take it. When they're free, nothing to do, they take it. When they're happy, they take it. When they have too much to do, they take it. When they can't sleep it, they take it. When they slept too much, they take it. So when there's a festival, they take it. When there's a death, they take it. So they just don't know when to stop. Every time, any emotion, any stress, any trigger, they rush to the substance. And that becomes a big problem, which needs to be untangled. Also, there are social issues, connections, the peer pressures we have, fitting into that population. I remember talking to Dr. Pawan, we both talked about when we both in college, we had so much difficulty because our friends will force us, "Arey, tu to cigarette nahi peeta, tu to daru nahi peeta, tu to kisi kaam ka nahi hai, useless hai." And that kind of ridicule you suffer in. So you do it to fit in. And so fitting in causes a lot of times pressure to people to do and once you start doing it, so after some time, it becomes a pattern and then you get stuck in it. Again, the family's behavior towards substances and the partner's behavior towards substances, that also affects. Now, the biopsychosocial model of substance abuse treatment, it talks because, again, I'm just repeating for everybody to understand that there's so many, different physical health is there. There is exposure to the substance. If you look at these cross sections, the drug effects, which can affect both the social and the biological, the temperament, which can come both from biology and from psychological issues. So all these together causes addiction, and that's why we need to address each and everything. So we need to take care when somebody's come for treatment to look at their physical health, try and help it. Any disability caused by substance abuse, we need to work on it. We look at any genetic vulnerability, how much exposure to substance they had, what kind of temperament they have, what belief systems they have, what attitudes they have towards de-addiction, what kind of self-esteem they have, what coping skills they have developed, or they have, mostly of them lack social coping. Same, they lack social skills. They don't know how to mix with people, how to go to a party without doing the substance. And what kind of family relationships they have. What traumas, because of substance abuse, there's a lot of trauma in their family. There are fights, there is issues, there are stealing. And then what kind of peer group they have. We need to help them change their peer group. What circumstances which are leading to substance abuse and the work they are in. So chances of success in drug abuse treatment can be increased by looking at the combination of biological, psychological, and social factors, which leads to substance abuse. So let's look at the principles of biopsychosocial model. It's important to remember that in this model, unlike the biomedical model where we talk with doctor takes all the command, or moral model or any other, here patient is openly talking with the physician or the treating team. So physician is more open, doesn't blame the patient for the disease. They understand that there is a genetic vulnerability which has led to patient doing the substance. It's important we need to create trust among all the stakeholders, whether it's patient, the family members of the patient, or the treating team. We need to encourage curiosity. If patient has any queries, कि मेरे को नशा क्यों होता है डॉक्टर साहब मैंने 6 महीने पहले क्विट कर दिया था, मैंने फिर स्टार्ट कर दिया, डॉक्टर साहब मैं क्या करूं? गिल्ट हो जाता है पेशेंट को, एंगर हो जाता है, आई एम डूइंग इट फॉर माय फैमिली, वो तो मेरे को अभी भी ताने मारते हैं, सो आई विल रीस्टार्ट इट. सो अंडरस्टैंडिंग इमोशनल रिएक्शन ऑफ दोस पेशेंट्स, acknowledging self-bias, that as doctors we sometimes are more biased. We say, oh, ये तो addict है, ये तो वैसे ही, we look down upon them, that we should not do it. Anytime any self-bias is coming, we should be careful about it. We need to have open communication. And this is one treatment which is evidence-based. There are much more therapy papers, which are more papers are done on CBT for de-addiction, medications for de-addiction, social interventions for de-addictions, preventive methods for de. So all of them, if you look at the maximum research is done in this area on biopsychosocial models. So that's why it is most of an evidence-based treatment. Now let's look at a few merits and demerits of the biopsychosocial model of addiction. The merits are, we do not blame the patient. So we don't assign blame. It's more holistic. We're not just saying, okay, तुम्हें हम दवाई दे देंगे, तुम दवाई खाओ घर जाओ, and that will take care of everything. No, we're saying, okay, we'll give you medicines to help you. We'll also take care of physical health. We'll take care of mental health. We'll do therapies to help you strengthen your ego systems, your ego strengths, your coping mechanisms, how to deal with peers, how to say no to peers who offer you substances. It's ever evolving because, the models we learn, the therapies we know, the evidence we have, it keeps getting better and better. And so it's ever evolving. The way we're going to do, like ICanCaRe is a good example. It is based on biopsychosocial model, their app, and it is evolving. As we get more experience, we evolve more. It's patient friendly, which is very, very important. We're not locking up patients. We're not looking down upon patients. We're treating them as humans who are ill and we need to help them. And it is also inside oriented. With biopsychosocial model, because we're talking to the patient, we're helping the family members understand the nuances of addiction, it's insight oriented. So patient starts getting idea. Acha, I got upset that the other day, that's why I smoked. Oh, because my friends pressurized me, that's why I smoked. So those kind of things. But there are demerits, because there are demerits to everything in life. One, we're giving too much information to the client. So sometimes when client is in a hurry, hey, doctor sahab, bas mujhe dawai de do, main theek ho jaun, bas mujhe ab dawai de do, I want to quit. Then this model doesn't work because they don't understand if you try to give too much information. And not all clients like information. It can create tension between patient and the doctor because, sometimes they say, doctor, this should be the treatment. Why are you doing this or why are you doing that? So because we are allowing open communication. So that could be one issue. And because we're dealing with family, we're doing a lot of therapies, it is time consuming. So it is not suited for short-term care. It is more suited for medium to long-term care. So some points to remember when you're doing de-addiction, especially for nicotine. Average quit attempts before complete recovery for nicotine is 8. So कम से कम 8 बार patient cigarette छोड़ता है और छोड़ना पड़ेगा. It takes so many attempts before the patient is totally out of it. So don't get frustrated if despite the best of your treatment, patient started again and again and again and again and again. 8 times is a big number. Remember that. Success increases when there is a plan. We should ideally address all 3 areas of addiction factors. All 3. So we We need to have a plan which looks at biological factors. We need to have a plan which looks at psychological factors, and we need to have a plan which addresses the sociological factors. And we have been talking about it in the past sessions. Biological, we have NRTs, we have anti-craving drugs and other methods. Psychologically, we need to have CBT to take care of triggers, targeting thoughts and behavior around smoking and stress management. And social, we need to develop coping to manage social triggers, social support for non-smoking lifestyle, change the immediate and intermediate environment of the patient, because we can't change the whole society, but help the patient and the family members come together. Like, if other family member is smoking cigarette, poor patient is sitting at home seeing the other person smoking, that's not going to help. That will be a little tough. So it's important to engage the family members. So with all this information, I just wanted to say thank you to all of you for listening. Thank you.
Indeed, a very enlightening talk, Dr. Vishal. So we will be taking questions right now, or what?
In the end, later.
In the end. Okay. So Dr. Vishal has highlighted all the points which we need to encompass when we are doing pharmacological interventions. Right? Because when we tell the patient that this is bad, this is carcinogenic, or this is going to spoil your health, or this is injurious to health, is not what the public is expecting. And that simply doesn't make them modify their behavior. Other important point that we have noticed in clinical practice is that pharmacotherapy alone doesn't work. So if whatever is the molecule that is being developed by the pharma industry, we are also, it saves a lot of time for a psychiatrist as well, that if that drug alone works, then nothing can be a better substitute for us. But unfortunately, the best of my experience, pharmacology, just prescribing a drug, it doesn't lead to any de-addiction. So always, that is a dictum, and that is a dictum, and that should be followed necessarily, that all non-pharmacological interventions, be it alcohol, be it nicotine, or be it any other substance, because youngsters are nowadays using a lot of cannabis. Different forms of cannabis is being taken along with nicotine. So many a times we are not getting pure forms, but we are getting patients abusing different forms of multiple drugs. So non-pharmacological interventions along with the pharmacological interventions, and a focus on relapse prevention, and a necessary focus on relapse prevention after essentially detoxification. That is the mainstay of the treatment, and that is evidence-based, and that is being what we see in our day-to-day clinical practice. So since we are not taking any questions right now, I think the next session can start.
Thank you very much, Dr. Shruti. Thank you very much, Dr. Vishal. It was a wonderful, enlightening talk for me, especially as a critical care consultant, about the multifaceted approach and the non-pharmacological and pharmacological approach combined. Yes, there have been lots of papers on it, especially during the COVID period when people are going, the reason for some of the people going back in isolation when they come back and say, oh, I was all alone. And, these multiple factors caused me to relapse. That's a big issue now. Let's go on. Thank you very much. And let's go on to our next session for experience with multimodal treatment in family practice. Our chairperson today is Dr. M.S. Bhatia, who is the director and professor and head of the Department of Psychiatry in University College of Medical Science and GTB Hospital, Delhi. He's been extensively involved in research and clinical experience in psychological problems, and he's been author for over 20 published books in psychiatry, neurology, psychology, and also more than 300 publications in all the various areas. He's won lots of awards for contribution in mental health, and his special interests include human relationship, consultation, liaison, and a lot of other psychiatry and mental health issues as well. Welcome, Dr. Bhatia, and the podium is yours.
Thank you very much. So as I congratulate the organizers for organizing this particular conclave, and I now request Dr. Pooja Patwardhan, who had experience of working in 3 different countries. He has been a very successful researcher, trainer, and also has a passionate in using innovative ways in tobacco cessation work. She'll be talking about her experience about the multi-modal method in family practice. So how it can be used, especially in different countries, for using in cessation the tobacco use, and also in preventing methods as a preventing method. So without taking much time now, I request Dr. Pooja to kindly continue with her presentation.
Hello, can you hear me?
Yeah, we can hear.
Okay, thank you, thank you. I'm just gonna share my screen.
Dr. Pooja, if anything I have not said about you, you can add to that.
No, thank you so much. Thank you. Give me just a minute.
So we are having 15 minutes, so 15 to 20 minutes you can have a presentation, and then we will continue.
Thank you, thank you. Sorry, give me just a second. I was trying to. Sorry about that. Make my screen bigger.
Want me to share the screen for you?
Yes, maybe do that.
Can you see my screen?
Yeah, but
it's not share full display mode.
Need to go on slideshow.
Slideshow. Go to slideshow. On the top panel, you see it's there.
Yeah.
No, below that line.
Besides the review.
Yeah.
Besides review.
No, I can't see that.
Go on the right side of that. Keep going.
Go on.
Next
right.
one. Yes, that's slideshow.
Okay, I think, you know what? Give me just a second.
No, left side. Yes, that's it. And go to.
From beginning.
Yeah. Yes.
Thank you so much.
That's it.
Okay, so firstly, thank you so much, Dr. Bhatia, for introducing me. And I'd like to thank Dr. Nimesh Desai, sir, and Dr. Pawan Gupta, sir, for giving me an opportunity to join this great venture you guys are conducting. It's amazing work and much needed. So, excuse me. So as I said, I work in UK, and with my role as a family physician, I get to see a lot of variety of patients, from pregnant women. I do 6-week baby checks, mental health problems, COPD, asthma, angina. But unfortunately, very, very few people come to me asking help to quit tobacco. In UK, of course, it's mainly smoking when we talk about tobacco, but we do see some people, especially South Asian people, who use SLT as well, and then shisha and other forms of harmful tobacco as well. And when I proactively start the discussion about quitting tobacco, quitting smoking, the commonest answers I get are, "Oh, I know tobacco is harmful to me, doctor, but it's not the right time for me to quit. Life is really, really stressful currently." Or then some people say, "I've been using tobacco for a long time and it's not done any harm to me, so I guess it's fine for me." And then few others would say, "Oh, I've tried to quit genuinely, but nothing works for me. So it's just not my cup of tea." I'm sure few other answers you would have heard as well. And people give these reasons for why they can't quit, why they are not ready to quit. And in that case, we think about why do people, despite knowing it's such a harmful thing, why do they continue using it then? And why is it so difficult to quit? And why relapse rates are so high? And main and most important thing is, what can we do to support these people quit tobacco? Now, I must thank Dr. Vishal for giving a brilliant explanation for this model. So I'm going to whiz through these slides. I had very similar things too, but I think it's good to see that so many of us are aligned on how we should support people in quitting. So as Dr. Vishal said as well, there are three important components of tobacco dependence. It's the physical component, the emotional component, and then behavioral component. So physical component, as we know, it's the nicotine addiction. So whether it's smoking or SLT use, the nicotine from that reaches the brain. It releases dopamine, which make people feel happy, stress-free for a short time. And then they keep on using tobacco, or in UK's case, mainly smoking, and they get addicted to it. They become dependent on it. When it comes to emotional dependence, we're talking about how people think they really need tobacco to just cope with their day-to-day stresses. They feel if they quit, they will just not be able to deal with regular days activities, regular ups and downs in life, and it becomes a crutch for them. So they really worry about what would they do, and that's why they don't want to quit. And it's the behavioral dependence. So once people start taking tobacco on regular basis, they develop a pattern. Usually they start consuming tobacco with specific activities or at certain places. For example, alcohol and smoking, it's very commonly known association. Similarly, tea, coffee, and smoking, people often, when they go for a tea break, they would use a cigarette at that time. And also some people, they develop a habit. So every time they are waiting at a bus stop, for example, while going to work in the morning, they would have their cigarette. That's their routine. Or maybe if they're driving alone to work, that's when they have their cigarette, definitely. And that's a pattern. So if they have not thought about these associations, and if they try to quit, what happens is, whenever they are doing these activities, or whenever they are taking a coffee, or whenever they're waiting at that bus stop, they get sudden craving, they get restless, and they don't know what to do then. So it's that behavioral association and dependence we shouldn't forget when we are supporting somebody in quitting. And I'm saying the same line as Dr. Pawan said as well. It's allegedly Mark Twain said, giving up smoking is the easiest thing I can do, because I've done it thousands of times. From a clinician point of view, I take it as a reminder for all of us that relapse is very, very common in tobacco addiction. And for us, we have to remember that, because we need to give self-help tools to every consumer, and we shouldn't just relax when they have managed to quit for 2 weeks or 3 weeks. We need to give them enough tools so that whenever in future they come across similar situation when they initially started using tobacco, whenever they started smoking or SLT use, they should have some tools so that they will not go back to that place again, and they will not relapse back. So it's something we need to bear in mind as clinicians, really. So what do we do? And again, I'm probably saying things which have been covered in the past talks today as well as in the previous talks, but it's good to revise so that hopefully all of us will remember. And this is from my experience, actually. If I just say to people, don't use it, it's really harmful, it's the wrong thing you're doing, what happens? It just gives a negative message. It's just nagging. There's nothing new. Most of the time, people have heard that either from other clinicians or through public health messages. And they probably want to quit, but no one has told them how to quit. And that's why they get that frustration, they get that guilt. It's just a lot of negative emotions. And it does affect the relationship between a clinician and the patient as well. So it creates that conflict, and no one wants to, the patient as well as the clinician don't want to go into that area again. It puts everybody off. And that's why it's important to, whenever we start discussions about tobacco cessation, we have tools to give to them to quit successfully. And hence, again, I'm probably revising few of the things which have been discussed, but when it's to tackle the physical dependence, it's NRT and other medications. When it comes to psychological or emotional dependence, it's the behavioral interventions. So with behavioral interventions in psychological and emotional things, it's the things that they can do for themselves to cope with the stress. As I said, it becomes a crutch. Often people use smoking as a crutch to cope with day-to-day stresses. So they need to think about how are they going to cope without that, and we should help them think about it. It's a bespoke thing really, for everyone's life situation is different. Whether they have family support or not might be different for everybody. So we can't give a blanket solution to everyone, but we need to give them solutions which we should just encourage them to think about it. So, and in my personal as well as professional experience, tools which release endorphins, so mainly music and exercise, these are, I've seen they work for a lot of people. So, and with technology these days, it's really easy, especially in the last year of lockdown, people can access lot of variety of music, exercise classes, and interactive sessions as well, very easily from anywhere and everywhere in the world. So something we can give them as tool when they are in a stressful situation. And with the socio-cultural things, the pattern. So I ask them to think about things, what they're going to do when they normally use tobacco. So let's take the example of bus stop again. So if someone is used to smoking at a particular bus stop every day, see if they can take a lift for 2 weeks maybe, just so that they just don't go near that bus stop, just to break that habit. Or see if they can walk to their office just for a few weeks. Can they not have tea and have some other cold drink for a few weeks maybe? So they need to have this plan in mind about what are they going to do when they normally use tobacco, definitely. And if they have a plan handy, then when they get that craving, of course, nicotine replacement therapy and other medications would help with the nicotine craving. But the habit part, if they have got a plan, that would increase the success chances definitely. And I would really like everyone to remember that withdrawal symptoms from tobacco don't wear off in a few days. Unfortunately, a lot of people who use tobacco, so consumers, but also clinicians, often think that it's fine. After a week, it's just their willpower. That's all they need, really. Anything they're saying, they're just making it up. Unfortunately not. You can see from this chart that many of really unpleasant withdrawal symptoms can last for weeks and sometimes even months. So whenever the patient has come to the stage when they are ready to quit, they've decided to quit, it's important we talk to them about these withdrawal symptoms, not to scare them off definitely, but to prepare them on what to expect. So and then also give solutions. So again, if someone's worried about constipation, we can easily give them laxatives for a few days, increase fiber, increase water in diet, simple solutions. But then they know that this is not long-term, it will go, but at the same time, they have got tools if they need to. And similarly, it's the safer nicotine in the form of nicotine replacement therapy. In UK, of course, we have electronic cigarettes as well, but in India, it is banned. So, but you can offer nicotine replacement therapy to combat with some of these withdrawal symptoms. So remember, withdrawal symptoms are preventable, predictable, and treatable. And in today's times, we shouldn't let, just the way if someone's in pain, as clinicians, we should offer them enough painkillers. No one in today's time should suffer. And similarly, if someone's trying to move towards a healthier life, we shouldn't let them suffer as much as possible. It's our duty to offer them the choice, whatever is available, and as long as it's not contraindicated, offer them enough tools so that they won't suffer when they are making the right choice of quitting tobacco. So this is just about kind of a summary really about practical challenges that tobacco users face and then what we can do for that. So it's important that wrong beliefs and misconceptions, so for example, things like mental health effects of tobacco. A lot of people, as you know, think that it's actually a good thing for them. Mental health patients think that it's helping their mental health and they're surviving only because they are taking tobacco. But as we know, actually, tobacco in the long term worsens depression, it increases panic attacks, and quitting tobacco is as good as using an antidepressant. So it's important that we tell them the real stories, but as I said, we have to give them tools as well to cope with the time when they are in that quitting journey and lack of support. So enough support, individual support, and not just a blanket solution, because often it doesn't work. Everyone's life situation and reason for using tobacco is different. So giving them time, giving them empathy, it's really crucial. And if I've seen in some of the material in across the world actually, that when people say you have to ask them whether they're ready to quit, and if people say no, they're not ready to quit, then we should just ask them to come back. But I slightly disagree with that actually. We need to find out why they're not ready to quit, because I've seen in my practice many a times people say they don't want to quit because either it's their own personal experience when they have failed to quit, or they've seen someone else who's failed. And as adults, no one likes to fail really. It's a natural thing. Who would want to keep on trying and then fail and keep on trying and fail? We need to give them confidence that actually this time we're going to give them enough tools, we're going to give them enough support to increase their success chances. And it's fine if they fail because we can try something else. It's important to tell them for different people, different tools work in different stages of life. So giving them enough tools, and also in the past talks, we've seen important to talk about enough quantities of NRT, enough and the right technique of NRT. Often they might have failed because they probably were not using the right NRT or the right dosage of Champex or Bupropion. They might have suddenly stopped it. They might not have tapered it down at the end of 12-week course. There are a lot of reasons why people might have failed in their past quit attempts. So I always feel, and I've seen that actually if we take some time out to find out why they have failed and why they are saying no now, many a times we can reason and then convince them to give another attempt to quit. And of course, we need to have enough clinicians. I completely agree with Dr. Gupta sir that we need enough people, enough clinicians who are trained to provide the right support, and we need to have enough support across the country, which is scaled and not just in one or two areas of country really. So and providing support throughout the quit journey, behavioral support, that's really important. Remember, relapse is very common. So self-help tools, and apps, how people can use single nicotine like NRT when they are at a risk of relapsing back, and where to go, how peer support, that's really important. I tell you what services we have here in UK. UK is at the forefront of smoking cessation in the world, really. We've done most good things. I'm saying most. I'm sure other people like Dr. Divekar who are from UK, you would agree that we can do a lot more here as well. But some good things, we have NHS, which makes life really easy. So everything is free, and people can access free service for behavioral support through local stop smoking services, and they can get NRT from there. And the good thing is here we do encourage choice, patient choice. So people should be given, even in my practice, whenever a person is ready and they've chosen NRT as their quitting tool, I would always discuss. So one is a long-acting one, which is a patch. Then out of the short-acting one, this is the choice. These are the pluses. These are the minuses. What would you like to try? What would you like to quit with? And then tell them that they can always switch as well. So from gum, if they want to move to mouth spray, that's fine. Doesn't matter. It's not a prescription like antibiotic course where there is a strict regime. Let them adjust the dose as well. People who are smokers, they know how to adjust their nicotine levels. They're usually quite good at it. So if we give them the control, if we let them own their decision to quit, results are usually very, very good. And of course, we do have prescription medications like Varenicline, Bupropion, and some other ones which are not licensed for smoking cessation, but are used in practice. In UK, as I said, we do have electronic cigarettes as well. And in many stop smoking services, actually currently there are voucher schemes for electronic cigarettes to encourage more people to try and quit using anything. As we know, smoking is really, really bad, and any quit attempt should be encouraged, really. App, it's a great thing in today's times. It gives us a very easy way to make things scalable. And in times like lockdown, people can access behavioral support, motivational tools through apps, which are fantastic. People can sign up for getting a daily email through the service, through the NHS smoke-free service. So every day they get a ping, okay, what have you done today? This is what you're going to get. People have, there are apps which give them an idea of how much money they have saved every day and how their pot is increasing. So that's a very good thing. There are also peer groups, peer support groups, either in the community, but also in today's times in social media. So in Facebook Messenger, NHS has a support group there, which again is a great tool. Peer support always in all other areas of medicine as well, we see it works really well. So that's something we do in UK. Now, I know these are a lot of cases. I'm not going to go into the detail of other medical problems. Just wanted to say to you, I want you to think about what's common. What is the common thing in history we need to ask for all these patients? And all these patients I've seen recently in my own clinic. So I've just picked up random cases to my clinic. One was a 6-year-old girl brought to doctor by parents with recurrent respiratory infection.
Dr. Pooja, we will have to conclude actually. We are running out of time.
The last slide actually. I'll finish in a minute. Is that okay?
Yeah.
Thank you so much. Thank you. So yeah, recurrent wheeze, already had antibiotics, steroids, inhalers. 23-year-old university student. Worsening depression, panic attacks, completely not happy. 68-year-old coming for a pre-op checkup for his knee replacement operation. 52-year-old man coming for annual diabetes checkup, saying, "Oh, very good, doctor, my blood sugar is very well controlled," and expecting a pat on the shoulder for that. 30-year-old housewife presenting with painless white patch on oral mucosa. So very diverse cases, different systems. Probably in India, I think all these people would go to different doctors, one pediatrician, one physician, probably a dentist. But I think the main thing we definitely need to ask all these patients, it's the history of tobacco use, history of smoking, and in some cases, history of use. And that's because in many cases, the outcome would significantly depend on that. In some cases, that would be the cause as well. Why I put these diverse cases is, again, to say that whatever your clinical specialty is, tobacco is such a big silent monster that it affects almost every organ in the body. And that's why it's every clinician's responsibility to get ourselves upskilled and then provide support in tobacco cessation, because very likely at least few problems coming to you are tobacco related, whatever is your specialty. So just concluding my today's talk. Quitting tobacco is not easy. So if patients are failing, it's quite normal. Unfortunately, keep giving support, keep encouraging them. Relapse is common, but give them tools and never give up. There are lots of different tools. We have to use combinations, dual therapies, but never give up, because something will work at some point, definitely. And as long as we provide patient-centric and comprehensive support, we are doing our duty as clinicians, because one of the best things healthcare professionals can do for their patients is to help them quit tobacco. Thank you, sir.
Thank you, Dr. Pooja. She had successfully talked about the patients' beliefs. They lack beliefs, they lack knowledge, they lack support, they lack motivation. So how all the challenges can be overcome. And she also talked about the NHS model, and also the take-home message. The important one is that it's not easy to stop smoking. And another one, that it should be, treatment approach should be multimodal. It should be patient-centric. It should be patient-centric rather than the physician-centric or center-centric. It should be patient-centric and should be comprehensive. And relapse is very common. So I congratulate Dr. Pooja for giving her a useful talk. Important one, she touched about the important point. And she has been the co-host also. I congratulate also Dr. Desai and his energetic team. And we already had more than 160 delegates who are participating in this particular program. So all the questions, they can be directed to chat box to Dr. Pooja, and that can be answered. Thank you very much, Dr. Pooja.
Thank you.
Thank you
so much. Thank you.
Thank you very much, Dr. Pooja and Dr. Bhatia, for this wonderful session. I just need to announce before this that there is going to be an exciting quiz at the end of this. And please do answer. There's going to be awards which are going to be announced next week in our final concluding session. So now we go on to the next session, Innovative Intervention for Sero, Role of Oral Screening. And let me introduce our chairperson for this session, Dr. Rajeshwar Nath Charan, who is a professor of molecular biology, Department of Biochemistry, School of Life Sciences, Northeastern Hill University, Shillong. He is a dean of School of Life Sciences, director of Design Innovation Center, approximately 40 years of postdoctorate research experience, 37 years at NEHU and approximately 2 years at JNU, active ongoing research in the field of radiation and cancer biotechnology and molecular biology, lots of publication, 115 books, and he holds 1 Indian patent and has filed for 1 more Indian patent under International PTC, serving as an associate director of handling of Journal of Radiation Research for over a decade. Welcome, Dr. Rajeshwar Nath. The stage is yours.
Thank you. Thank you very much, Dr. Nandita. It's wonderful to connect. Before I introduce my speaker, I must like to put on records my special appreciation of Dr. Desai and Dr. Pawan Gupta for inviting me to this. Dr. Desai is an old friend and dear friend, and he messaged me that I have to join. So this is the first time I joined this ICanCaRe forum. He just messaged me that you ought to come. And I said, you are the boss. You order and I'm here. And so I'm I'm very glad to join this August body on the third day of this beautiful session. Many compliments to Dr. Pawan Gupta. Now, I have pleasure to chair this fourth and the last session of today. Dr. Vasanti Jigre is the speaker today, a very astute dentist. Has bachelor's and master's in dentistry, and she has been working in oral medicine and radiology at KLE VK Institute of Dental Sciences. She has co-authored 2 books at least, and she's also internationally certified life coach. Dr. Vasanti Jigre, you welcome. 15 to 20 minutes is the time that is allotted by the organizers for this meeting. So Dr. Vasanti Jigre.
Thank you so much, Dr. Rajesh Sharan. I will begin my presentation without further delay. So sharing my screen right now. And do you see a slideshow?
Yes, absolutely.
Okay, thank you so much. And at the outset, I would like to thank the organizers of the International E-Conclave on Tobacco Cessation. I'd like to also thank Dr. Reena for providing me this opportunity. And it's an honor for me to share this platform with so many eminent experts from different disciplines. And I also have a confession to make. I have never spoken for such a short time, so pardon me if I exceed by a few minutes, or if you may find that some information is missing in my presentation. And just to stay on time, I'm also putting my timer on. And so right now we're going to talk about role for oral screening. Greetings to you all from KLE VK Institute of Dental Sciences, Belgaum in Karnataka. It's a very beautiful city, and we have a really wonderful college and campus out here, which I feel you must all visit at least once. So my presentation is going to follow the following outline: tobacco usage and its forms, effects on body, which is already covered, so I won't be going to dwell much on that. Then effects on oral tissues, and about screening, and also recommendations. Well, we've seen the dangers of smoking, and a lot has been discussed about smoked tobacco usage. So let me give you some insight into smokeless tobacco usage in India. And according to WHO statistics, 81% of world smokeless tobacco users live in Southeast Asia region. And India also figures on the top of the list among the numbers in terms of usage. And although we found that a lot of people are trying to do a lot of things, it is still a little difficult. It seems to be a huge task to get people to quit usage of tobacco, whether it's in the smoked form or the smokeless form. It has been found that bans on advertising can reduce consumption. And there also we found that the figures are dismal concerning the number of people who have quit tobacco usage. And delayed diagnosis in terms of tobacco-induced oral changes have been attributed to socioeconomic status, then literacy, education, and is also found that delayed diagnosis of oral problems are more common in low and middle-income countries. And early diagnosis is also associated with patients who visit dentists. And coming to oral lesions, we find that oral cancer is predominantly common in the Indian subcontinent, and there's a high incidence because of delayed diagnosis. It is also associated with a low 5-year survival rate. So a lot has been discussed about tobacco. There's another thing that warrants interest and attention is usage of gutka or areca nut or betel nut, also known as supari and pan masala, in different parts of the country. Now this is something that has not been discussed adequately, I've seen so far. So this is something else also which has a great addiction potential and is greatly associated with malignant changes and also potentially malignant changes in the oral cavity. So out of all the smokeless tobacco users, 31% of them are smokeless tobacco users, and in that gutka users are also quite a high number, that is pan masala and supari. And to be honest, there was a brief period in my life when I was also hooked to supari because it had some really great flavoring agents, and also you can see the kind of effect it has on people when it is nicely flavored and packaged and also marketed. So for that reason we find that there is a great amount of usage, and highest usage is found among younger populations. We have seen in my practice in the clinic, in the college, we find that tobacco and gutka associated changes are becoming increasingly common in younger people, even as young as 15 to 20 years. You may find that hard to believe, but this is what's happening. And an interesting fact is that if we ban all this, then this is the amount of losses we are looking at in terms of business and the impact it will have on the nation's economy also. So it's a kind of a cliffhanger. What do we do about it? So along with tobacco usage, we have to talk about usage of an addiction to gutka or supari. This is another thing that needs to be addressed because it also has a very, very bad impact on the oral cavity in a long duration. So different forms of tobacco are well known to everyone, and areca nut also is available in many different forms, and it is packed and marketed in very attractive packaging, making it very interesting for a young buyer to go and get hooked onto. And effects of tobacco consumption on the body are well known, but then what about effects of tobacco and gutka consumption on the oral cavity? So before we go into that, the next question, who and where regarding to oral screening. So oral screening happens in dental colleges. Every patient who walks into a dental college has to go to the Department of Oral Medicine and Radiology, and that is where every patient gets a thorough oral exam, and this is where we also screen for through history and through examination effects, signs and symptoms of tobacco usage on their oral cavity, both the teeth as well as oral soft tissues. Then dental clinics also, dentists examine thoroughly in their clinics also and identify patients who are using tobacco, either the smoked form or smokeless form, and then are in a position to offer treatment. Then another thing that can be done through community dentistry or through a dental college as well, and along with government support, is door-to-door visits. If we are looking at mass oral screening, then door-to-door visits are a good way of screening the general population at large. Then we have found that a lot of factory workers have a high prevalence of tobacco usage. So on-site screening, we have done this as a part of a project in the past. I'll talk details about it later. Where we screened factory workers for potential for transformation to oral cancer. And awareness and screening camps by oral physicians and public health dentists are a good way for oral screening, large-scale screening, and also to create awareness, to educate people from all different sections of the society, different age groups. So this is another way of achieving it. Then coming to mobile health. Now we spoke about technology, we spoke about apps, and this is one of the projects which I was a part of a few years ago, using a mobile health for remote diagnosis. And we conducted camps in many different areas where an algorithm was developed to determine the potential for development of a potentially malignant disorder or oral cancer in patients who have the habit of tobacco or supari usage. So it was a good study, and we found good results. And so the role of an oral medicine specialist was to do remote diagnosis and screening and recall of patients using the mobile app for further intervention in the terms of de-addiction counseling and as well as management of any oral mucosal changes. So when do you do oral screening is, well, first of all, whenever a medical professional finds that the patient is a user of tobacco, they can refer the patient to a dental college, to a dentist. So for further treatment, and also we also do counseling, and with this there is identification of lesions in early stages leading to better treatment outcomes, better survival rates and lower morbidity. Now, why is oral screening necessary? Oral screening is necessary because tobacco leaves a lot of signs. Tobacco usage and supari usage leave a lot of signs behind, a lot of deleterious changes, harmful alterations in the oral mucosa. It affects the teeth in a way that it leaves the staining of teeth, whether it is smoked or smokeless. Then periodontal status, that is the supporting tissues, the gums and the bone supporting the teeth, are also affected. There is gradual weakening of the support to teeth, leading to loosening of the teeth. Then there are also tobacco-induced mucosal alterations and also potentially malignant disorders that are seen in the oral cavity. If left untreated, these will many of these transform into oral cancer as well. So depending, here are a few pictures which some of you may already be aware of. So whether it is smoking or smokeless, you will find staining on teeth. Depending on the extent or depending on the frequency of usage, staining may vary from mild to really severe, complete coverage of the entire tooth surface. So this is staining of teeth. Then you'll also find that these patients have recession of their gums. So root surfaces get exposed. So these are all effects which are irreversible. Then in the mucosa you find early changes or intermediate changes and even advanced changes. So early changes are reversible, leading to better outcomes, whereas as it progresses, as the habit continues unchecked, we find that the lesions might be advanced, leading to morbidity, or you might be able to intervene to limit the progression of the disease. So what are the different types of changes? Well, we saw early, intermediate and late stage, and some of them may be benign, they may be potentially malignant or even malignant. So early changes could be found in the palate or in any of the mucosal surfaces. And what are some of those lesions? Let's take a look at a few pictures. Then the advanced changes can be dysplastic or even carcinomatous changes. So we have white lesions, we have red lesions, and then we have mixed red and white. So generally the white lesions have better outcomes, but as they turn red and the red component increases, that means dysplasia is generally increasing, and that has a greater chance for malignant transformation, and those should raise red flags. This is why every patient who walks into a hospital with tobacco usage habit has to be referred to a dentist or to an oral physician, an oral medicine specialist, where they will screen these patients for potential changes and also advise treatment and also perform de-addiction counseling for these patients. So this is smoker's palate. Smoker's palate in cigarette smokers is generally harmless, doesn't turn into a malignancy. But if the patient has a habit of reverse smoking, that is when you have to be concerned, because this has a greater chance of developing malignancy. Then white patches are commonly seen in patients who are smokers at the commissure. Okay, so this area is commonly affected in smokers. So this is something that should be treated. Then we have something known as a lichenoid reaction, which is induced by betel quid or tobacco or even supari, that is areca nut or betel nut. So this is a reversible condition. Once the patient quits the habit, it will disappear. But if it persists and the habit continues, then there are other carcinogens present in the quid which can lead to potentially malignant changes in the mucosa. Then we have other changes. This is leukodema here on the left. So this is an opalescent mucosal change which disappears on stretching. Then look at this picture here. This is called tobacco pouch keratosis. So patients have the habit of, rubbing a bit of tobacco on their palms and putting it in the buccal mucosa or even in the labial mucosa, and they leave it there for maybe hours together and then either spit it or swallow it. So these are all the changes that have to be screened That's why oral screening is important. Now, leukoplakia is a white patch. It can occur on the buccal mucosa, it can occur on the tongue, but if it occurs in the floor of the mouth, then the tendency to develop malignancy is greater here. This is another example of tobacco pouch keratosis here in the buccal mucosa. Then oral submucous fibrosis is a chronic condition which is caused by usage of supari, consumption of supari. This is not caused by tobacco, but it is the most important etiologic factor is use of supari, consumption of supari. Now the problem with oral submucous fibrosis is in the early stages, it is okay, patient is not aware of the problem, and if it continues unchecked, then it progressively leads to decrease in mouth opening and so many other problems. And this is another lesion which can turn into a malignancy. So we have seen a lot of patients with oral submucous fibrosis who have difficulty in opening their mouth and have also developed a malignant transformation, an ulcerated lesion in their oral cavity. And once it transforms into a malignancy, we are all aware of how significant it is in terms of morbidity and mortality and the impact it has on the finances of a patient. So this is oral submucous fibrosis. You can see pale mucosa. We call it a marble-like appearance. There is a progressive decrease in mouth opening, and in the earlier stages when restriction is less, trismus is less, these patients have better outcomes. Like 3 to 4 centimeter mouth opening is generally fine, but as it progressively decreases, we have seen some patients who do not have even 1 centimeter interincisal distance. So such patients, these people are not even aware of the problems of using tobacco and gutka. It is so deeply ingrained in our culture and in our beliefs that they are completely oblivious to the harmful effects of using tobacco and supari. So what we need to work on is much deeper than just counseling. We probably need to work on a shift in our mindset regarding the usage of areca nut as well as tobacco. Now, once again, reasons for delayed diagnosis, it's a repetition. So these are all the reasons for delayed diagnosis as to why patients are not diagnosed early, leading to poor treatment outcomes and morbidity and mortality. It's primarily lack of awareness and also the socioeconomic status not permitting them to seek treatment early, and socioeconomic status is also linked with awareness, linked with education levels. So all these together, this is multifactorial. So reason for delayed diagnosis is again multifactorial, and that's the reason we see more and more numbers of oral cancer and potentially malignant disorders. So these patients, now every smoker, every smokeless tobacco user does not visit a dental clinic or a college. So that's the reason a lot of patients go undiagnosed, undetected. That's another reason why we should work for or promote interprofessional collaboration, a multimodal approach for tackling this problem. So what is the role of dentist or an oral physician? So as an oral medicine and radiology specialist, we are also oral physicians. We conduct thorough examinations of oral cavity. We have chairside diagnostic procedures that are done. Then we also have de-addiction counseling by certified dentists. So there are certification programs for tobacco de-addiction counseling. Then medical management is also done by oral physicians and oral physiotherapy. So physiotherapeutic modalities are also used to tackle problems of restricted mouth opening. Then where restricted mouth opening is not present, medical management is done, and then diagnostic procedures also. So oral screening plays a very important role in early diagnosis and survival, because of which we will see that it will reduce mortality as well as morbidity and improve 5-year survival rate. Now, early diagnosis is also necessary for minimum intervention. The concept of minimum intervention is gaining traction now in dentistry in terms of minimum intervention dentistry and also minimum intervention oral medicine. And how is this achieved is by early diagnosis and by having point of care diagnostics and using mobile health application for screening and early diagnosis. Chairside diagnostics also plays an important role for early screening. We have a lot of lab-on-chip technologies that are being developed. So why I'm talking about lab-on-chip technologies here is once a patient enters into a de-addiction program, you can periodically monitor his commitment or her commitment to this by checking for salivary biomarkers to see whether they are actually following the de-addiction protocol or not. So one such thing is the OFNA set, which is a lab-on-chip technology where tobacco metabolites which are detectable in saliva can be used to monitor their commitment to de-addiction. So my recommendations for a multimodal approach would be oral examination screening by dentists or oral physicians, then using an interprofessional approach to de-addiction with medical dental professionals, then with psychotherapy using behavior modification and pharmacotherapy, and increase the awareness using different media platforms to enlighten the masses regarding ill effects of usage of tobacco, gutka, then also recommending regular dental checkups, no matter how remote their location is, and also.
Dr. Jirgai, I just hate to interrupt, but it's about time, so maybe a minute or two you can sum up.
Yes, of course. I am almost done. Thank you. Thank you for the update. Thank you for the alert. Sorry. So by increasing awareness, we are doing. That is one of the ways of using a multimodal approach, and also early diagnosis for minimum intervention and better outcomes. Then population-based screening with visual examination is another important aspect of multimodal approach. We need to have population-based screening to determine the prevalence of tobacco usage and also motivate these people to quit the habit of tobacco, and worksite screening where factory workers are concerned. So at CaRe we have a tobacco and gutka registry. We have a de-addiction specialist who also enrolls these patients into a de-addiction program. And like we saw in the previous presentations, it is we can't say we have a 100% success rate because it is very difficult for these patients to quit. Then we also do management of oral tobacco and areca nut induced problems, both medical as well as surgical by the surgeons. So in the end, I feel that awareness, accessibility to care, early diagnosis and intervention, and an interprofessional approach is important to tackle this problem. So with that, I come to an end of my presentation. Thank you all for the opportunity, and over to you, Dr. Sharan.
Thank you very much. I think it was a very lucid presentation by Dr. Vasanti Jirgai. In 20 minutes, I'm sorry that I had to interrupt, but I think you were just about time, and it was wonderful. And I'm so happy that you talked about non-smoking tobacco, because that's where I have worked for almost 4 decades, and in the Northeast, which I perhaps you know already that it bears the biggest burden. I just want to add that almost 90% of women in this area use smokeless tobacco in various forms. And that's very, very worrying for me as a scientist, because I know what genetic implication it has on propagation of this genetic vulnerability to get addicted to smokeless tobacco. So it was a very, very dear topic to me. I also know that this is a big problem for this CRO, this whole region, comprising about 11 countries in South Asia. And, the burden, as you rightly said, is over 81% from that point. So it's a very, very, she has talked so lucidly that it's very difficult for me to summarize, but to say that it was a wonderful speak. Some points, of course, I know that a lab-on-chip technology is very, very important and it's going to help. But when I look at our country, India, where 80% people live in remote areas and villages where even primary health care is difficult, and that's where the burden of smokeless tobacco and smoking tobacco is biggest. And I think we ought to focus on On early diagnosis, one of the points that you said that is very, very important, because I know that early diagnosis and oral malignancy particularly, because it's so easily accessible, that it can really deburden and stop. I mean, the curative kind of therapy is possible only there with a very high success rate, because late diagnosis means almost 80% chances of failure finally. Yes. So that's very, very important. And I think the point was very well made. I just wanted to also that this very interesting data that we have lost due to ban on smokeless tobacco to government exchequer is very high, 15 to 20 billion rupees in 2013. But I must also point out that at the same time, the loss to the nation, which is actually to the government, in terms of loss of man-hour, in terms of healthcare expenses, far exceeds this figure. So I would definitely encourage that that it has to be seen as a good balance, and in that we have been doing some camps with the help of Center for Health Research and Education, from where Dr. Patwardhan was a speaker. And in our experience of early diagnosis and kind of using, and we are trying to develop some kind of artificial intelligence based remote help, where we can bring this tool for early diagnosis to the remotest of area and bring a bigger, because the load is enormous. So it's a very, very wonderful talk. I was very happy to be listening to it, and I hope we'll interact more to take it in the future. Thank you very much, Dr. Nandita. It's over to you.
Thank you very much. It's a wonderful talk, especially interesting about the salivary cotinine test, which I think there's on the chat as well, and it got my attention very much. Just wanted to thank you for your wonderful talk and the wonderful pictures you showed for us as well, and Dr. Sharan as well for your sharing and giving us all the information. So with this, a wonderful thank you to all our speakers, Dr. Gupta, Dr. Vishal, Dr. Pooja, and Dr. Vasanti, and to all the chair people, Drs. Patel, Dr. Shruti, Dr. Bhatia, and Dr. Sharan. Thank you very much for the wonderful, interesting session, lot of information. And I think Dr. Nimesh wanted to give us a small advice or some.
No, thank you. I know, I just wanted to flag that one, it's been great. Pawan and team and ICanCaRe have been great along with Dr. Reena. I just wanted to flag that on the 25th, next Sunday, I need to summarize toward the end of the afternoon the consensus statement. And so a few of the points that I quickly want to highlight, that if any one of you here today will please send by email or WhatsApp your ideas. One, of course, multimodal approach. Quit rates, what do we believe the quit rates to be? All harm reduction approaches. Do we envisage an algorithm for different clinical situations? I really do wonder, and of course, Dr. Pawan and a few other colleagues, we will interact more, but would we envisage by next Sunday 2 or 3 possible algorithms? What's come up today has been also great about psychosocial model and how do you combine. What we don't have still today is how do we combine different approaches, and I'm going to try and pick minds and brains on that in the next one before I summarize next Sunday. The last thing I want to say is that the talk by Dr. Vasanti has brought out Dr. Rajesh has been working for a long time on. Pawan, we need to perhaps think of new terms like that is not only SLT, which a term that I don't like. Smokeless tobacco is a Western word as a treatment method, but chewing or use of tobacco, like Vasanti highlighted, you know very well, and Dr. Rajesh knows very well. We could have start thinking and talking about the health effects of non-tobacco chewing habit. Come up last Sunday, 2 weeks come today. So those are the few points that I had. Also, what do we learn from, what lessons do we learn from alcohol treatment and prevention? A lot of our psychiatry and mental health colleagues are here. So my major point is, please, everybody who is here, please be here next Sunday. And if you have ideas, please send them on to me so that we'll have an attempt at consensus statement next Sunday toward the end. Thank you so much.
Thank you very much, Dr. Nimesh, for your brief talk. And we will be there next Sunday. I'm sure loads of people will be there as well. Can we go on to the next slide? We now, in interest of time, we'll go on to the next slide, please. Risha? Yeah, the next session is the interesting panel discussion. My duty here is to introduce Dr. Ashish Deshpande, who is a moderator. No, that's the wrong one. Can we go on to Dr. Ashish Deshpande's one before? Yes, Dr. Ashish Deshpande has done his graduation and post-graduation from, say, GSMC in KM Hospital from Maji, Mumbai. He's a program director, Samarpan Psychological Wellbeing and Rehabilitation Services in Mumbai. And he is also the director of the Center of Mental Health Advocacy Research and Treatment Services. He has a lot of ongoing research projects, and he's an ideator and advisor of De-Addiction Connect, Community Place Rotary Facilitated Addiction Prevention Initiative, and also for the Indira Gandhi Institute of Developmental Research Campus Assistance Program, ICAP. Over to you, Dr. Deshpande, for the wonderful panel discussion.
Yeah, thank you, Nandita, and thank you, ICanCaRe Foundation. I think it's wonderful to meet people from all across the globe, and thanks, Dr. Pawan, that we are meeting here and trying to discuss an important topic of tobacco, because we all know that it causes a lot of morbidity and mortality. And still, it's the opinion that people usually have about tobacco is very permissive. And it's something that is never criticized, never objected. And that's for generations together. A particular role model is carried through, and the young kids get vulnerable at vulnerable ages, take to these products. Well, today we have a panel discussion and we are a little short of time, so I would like to cut short the questions. But before that, let's go to our chairpersons, and we have Dr. Sandeep Kadam, who is a practicing pediatrician since more than 30 years. And he is a visiting consultant at one of the eminent, prestigious Jupiter Hospital in Thane. And he is immediate past District Governor, Rotary International. Welcome, Dr. Sandeep Kadam. And we also have my colleague, my friend from KEM Hospital, Dr. Harshut Thakur. He did his MBBS with me and MD in Preventive and Social Medicine from KEM Hospital. And currently he holds the director's post at National Institute of Health and Family Welfare. He has been extremely helpful in getting me the NIHFW clear approval for the research program that we are doing on preventive aspect of substance use. He is also a professor at School of Health System Studies at Tata Institute of Social Sciences in Mumbai. And he worked at the Department of Preventive Social Medicine in our college for a pretty long time, from 1993 to 2000. So welcome, Harshat, on the conclave. And we have a lot of eminent doctors here. We know that the morbidity and mortality of tobacco goes into all various systems of human body, and cardiovascular system, respiratory system, and cancers being the predominant ones. We have pulmonologists, cardiovascular system experts, and oncosurgeons on the panel. Along with them, we know that as Dr. Jirge said, that there are lots of complications that happen in the oral mucosa. So we have somebody who is a expert in that field right from Sydney. And we have one more information technology expert right from ICanCaRe Foundation. Please go to the previous slide. So Dr. Lancelot Pinto, I've known him for a long time. We share the same city, and he has been at Hinduja Hospital, has been a pulmonologist of repute. But what probably distinguishes him differently is of course he's got a gold medal in DNV and he has trained in McGill University. But I believe that he has been conducting nicotine clinic for donkey's years in Mumbai. And as a young pulmonologist, as he joined, and he initiated something that usually pulmonologists in those years would not initiate. And that is something that probably distinguishes him from the rest. And of course, he has a busy practice in pulmonology, and he treats all kinds of complicated cases that he gets. So that's Dr. Lancelot Pinto. Let's go to the next. Dr. Jayesh Patel, I have been introduced to him as Dr. Pawan Gupta's teacher, mentor, philosopher, guide, and friend. So he has been introduced before also. So welcome, sir, on the panel at the last moment because the other oncosurgeon was not available. So thank you very much for being there, Dr. Jayesh. The next slide, please. And we have Deepak Raheja. He comes from my biradari. He's a psychiatrist and he's from Delhi. He is the vice president of Indian Association of Private Psychiatry. He's on the National Executive Council of Indian Association of Private Psychiatry. Hope Care is one of the brainchild of his, where holistic psychiatric treatment is offered. There are inpatient facilities, outpatient facilities, group therapies. I know he does a lot of work in de-addiction. He started a wellness hope, the educative arm of Hope Care, and he has been awarded the Indira Gandhi Priyadarshini Award by Government of India. So congratulations for the award and welcome to our program, Dr. Deepak. Then we have right from down under Dr. Garima Sharma, who is an endodontist and practicing in Sydney. She is involved in teaching of dental students at University of Sydney, and she's the vice president of Australian Society of Endodontology, the New South Wales branch, and recently felicitated by Hindu Council of Australia for contributions to science. And we have Dr. Rakesh Kumar Chawla. He is a pulmonologist and a senior consultant of respiratory medicine, critical care, sleep disorders, and interventional pulmonologist. He's a chairman of Department of Respiratory Medicine and Care and Sleep at Saroj Super Hospital in Delhi, and working as a senior consultant in respiratory medicine in Delhi. He's a consultant, Department of Respiratory Medicine, and senior consultant, Ministry of Health Kingdom of Saudi Arabia. Dr. Chawla is one of the topmost international pulmonologists with more than 30 years of experience. And he is a pioneer and has done maximum cases of endobronchial placement of glue in cases of hemoptysis in India. And he is a member of Governing Council Chess Society and is elected zonal chairman of Indian Chess Society. And we have Dr. Dilip Kumar. He's a cardiovascular system fit as a fiddle. He's an interventional cardiologist and electrophysiologist and a chief academic coordinator, Medical Institute of Cardiac Sciences. Professional experience of more than 20 years under his belt. He is well versed with pacemaker implantations and all the electrophysiological procedures that a cardiologist usually is. And Dilip Kumar has been awarded as the most innovative cardiologist in West Bengal, as the healthcare pioneer of East, awarded by the Times Group. Next. And along with that, we have a technologist, where else from but IIT, who has been, I think, a backbone of ICanCaRe Foundation. He did his BTech and MTech from IIT Kharagpur. He worked with Samsung, and then most likely he left his lucrative job in Samsung to go for something that was very dear to him, some kind of community work. And that's how he came to ICanCaRe Foundation. And he is, I think, the brain behind all the apps that ICanCaRe Foundation has developed, all the social media presence that that ICanCaRe Foundation can garner. So thank you very much for all of you being there with me. We would, for the want of time, we would probably have to curtail the questions a bit. So pardon me. Well, I would like to ask, go with Dr. Deepak, to ask you, sir, why do people consume? Why do people consume tobacco in the first place? Any ideas? People know for years that they have lots of, tobacco has lots of complications. Why? Why still do they go ahead and consume tobacco?
Sir, good evening. Am I audible?
Yes, yes.
Thank you very much for having me here this evening. And thank you very much, Dr. Deshpande, even for the paucity of time you took, very meticulous details in introducing all of us. Thank you very much, Dr. Sai, sir, and Dr. Pavan Gupta for having us here this evening. Coming back to your question, because I know we are pressed for time today, why do people get addicted? I mean, after this very elaborate session that we've had this evening, with speakers doing more than justice to the topics assigned to them, I feel there is little left to be said. But at the cost, at the expense of paraphrasing what has already been said, I think tobacco is perhaps one of the most addictive substance available on earth to mankind. And I do really think it is perhaps more addictive than crack cocaine. A lot of literature says that. More people die because of tobacco-related complications than they die for many substances put together. Yet we are dealing with a substance that's legal, that's available in the vicinity, next door, and we tend to, like Dr. Vishal said, Dr. Pooja said, and then the speakers thereon said, it is a substance that has very intense psychological underpinnings. It has very intense behavioral underpinnings. It has very intense biological underpinnings. So putting that all together, we deal with a substance that instantly crosses the blood-brain barrier. It goes and binds with certain receptors, begins to produce a trickle of the reinforcing pleasure neurochemical called dopamine. You know, the same neurochemical that gets us addicted to the social media, that gets us addicted to all pleasurable stimuli. And here we have a substance that perhaps repetitively goes on to start firing the neurons with the help of dopamine, thus leaving the brain vulnerable to want more. Ye dil mange more. The high comes, and then the crash comes, and then the high comes, and then the crash comes. And we get addicted to the butt because it becomes cool. I think alcohol and tobacco, both legal substances, they are lobbied surreptitiously, so cleverly by governments across the world, because it is a big revenue churner. It is a big tax churner for governments, for politics, even though the tobacco farming is one of the biggest feeder to the farmers, but it also operates in a lot of ways with cartels that make huge amount of profits. And for them to surreptitiously slip up a part of those profits into perhaps very covert advertising, where in a movie, on a television screen, in the environment, you start picking up cues which perhaps reinforce that smoking is cool. It takes away stress, you have a feel-good factor, and then 7 on 10, some studies even say 9 on 10 smokers They desperately want to quit. They perhaps keep making plan that they're going to quit, but they never quit because they're also interwoven, embedded with the thought. Like again, for the fourth time, repeating what my preceding speakers have already said. Mark Twain, quitting to smoke is the easiest thing in the world to do. I have done it thousands of times. So I plan to give it up, but I know I will not be able to give it up because that becomes a way of life. It becomes a way of life for me to think creatively, to write creatively, to talk to my patients creatively. If I'm a surgeon, to operate creatively, to bust stress as soon as I come out. So I think Dr. Deshpande, maybe kind of gives us an answer to why people get habituated and they get addicted to tobacco.
Right.
Nicotine.
So at a vulnerable age, when people actually make a choice of taking the first smoke, at that time, a lot of information on why they should take up the butt is available, but why they shouldn't is unfortunately not available. And that's the reason probably the hedonic calculus makes them take a decision that maybe I can try it out. Once the person starts smoking, the first people that probably come to know is, of course, the parents, and the parents don't give it too much importance or whatever. But of the health professionals, there are family physicians, there are dentists, and there are pulmonologists. These are the three people who probably see the patient to begin with. So I would like to ask Dr. Garima that I'm sure that when you go to the close quarters of an oral cavity, the whiff of cigarettes must be the first alerting factor that must be letting the endodontologist to know that, okay, this guy is a smoker or this person is a smoker. And maybe as Dr. Jirge said that in her presentation, or Dr. Patwardhan said in her presentation, that they're not even willing to consider that there is a problem. So in such situations, what do you do? How do you initiate a communication or a conversation about tobacco cessation?
Hello, good evening, everybody. Am I audible?
Yes, you are.
Okay. Thank you, Dr. Deshpande, and thank you, Dr. Pawan Gupta, sir, for giving me this opportunity. It's good to be connecting across the globe to everybody, and it's a great initiative by ICanCaRe, and I think Dr. Pawan Gupta, sir, is doing great. That's actually a very good question. I think we as a dentist see the oral effects of smoking, as we have seen by Dr. Jirge's presentation, that there is a lot of impacts of smoking, right from cosmetic effects like staining of the teeth to more harmful cancerous lesions. It has an impact on the periodontal disease. So whenever these patients come to us, we can see that they are more at a risk of periodontal disease, at least 3 to 6 times more than any non-smokers. We see receding gums. We can see, more tooth mobility, red and white patches. So whenever we do an oral examination, I think if you see something which is a little bit unusual than the rest of the patient, then it's very important as a dental clinician that you ask the history. Is there? It's very important you ask them, do they smoke? If they do, then you need to assess what is their nicotine dependence. Of course, many people are not receptible to being told that they need to quit smoking. Some of them are, some of them are not. So if they are not receptive to listening or to be told that they need to quit smoking, then it's very important, and we have a behavioral therapy or a motivational therapy in order to point them to the right direction. And in Australia, there are a lot of like ICanCaRe, there is ICanQuit, which is pretty similar name as well here, which is a government funded schemes that actually motivate people and put them into the right path towards smoking cessation. And also, whenever we do that, whenever we advise them, and if they are motivated to quit smoking, we need to also tell them that what are the impacts, what are the implications. It's just not a impact on the health, but also the oral health. It does have an impact on their, overall well-being of the patient. So it's important that we motivate them, we encourage them, we put them in the right path of smoking cessation. We arrange follow-ups to see if they have started on their journey or not. And it's very important, especially here, everybody is very keen on their oral health. So we do have actually 6 monthly checkups here, which also helps us to do regular oral health screening. So we make sure that if there are any changes in the oral cavity, it's being picked up pretty early.
Yeah, yeah. Let me go to Dr. Lancelot here. Hi, Lancelot. Good to have you here. And the question to you is, Dr. Garima said that, well, before even any pathology appears, there are some things that you need to communicate. As a doctor, you just have to tell them that you are smoking, it's not good for health, blah, 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 blah. And would you like to do something about it? Whether it's an oral problem or maybe some kind of a smoker's cough that you see in the OPD, how do you get along with those patients with having a conversation about tobacco cessation in your clinic?
Thank you, sir. Thank you for that generous introduction earlier, and thank you for inviting me to this. I think I'm in a fortunate position by virtue of being in a respiratory clinic where somebody who's coming with a respiratory problem is far easier to convince than somebody out there in the community who perceives oneself as being absolutely healthy while continuing to smoke and therefore wonders what is the need to give up smoking. However, that being said, I think nudges always help. I think there are studies which have shown that just a brief counseling of about 5 to 10 minutes by a physician, just kind of sensitizing the patient about the fact that he or she is smoking can actually improve quit rates by about 2 to 3%. And, that sounds like a small number, but on a population scale, it's definitely big and it's multiplicative. So every time the person comes, if the person goes to multiple doctors, has different points of contact, even with the general practitioner, if it's said over and over again, I think that serves as a nudge. It also helps to think about the different non-health related nudges that you can give. For example, it's a known fact that children of individuals who smoke tend to have more middle ear infections, tend to have upper respiratory tract infections more frequently than children of those who don't smoke. And I think children are a point where it's a nudge. When you speak to a person about their children, it's easier to convince them about behavior change than when you speak about their own health. In addition to this, of course, at a community level, smoking helplines, which are there, advertisements of any kind will always help. The reassuring statistic, though, if you look at the Global Adult Tobacco Survey, the reassuring statistic is that more than 90% people in India, even in rural India, believe that smoking is bad for their health or consumption of tobacco is bad for their health. So I think the knowledge is in place. Close to 50% of them tried to give it up in the previous year. So the motivation, at least in a half of them, is already in place. And I think this, what we perceive as a lack of motivation is very often a lack of confidence, which has already been mentioned before as well. People have tried to give it up in the past, people have failed. And therefore, to cover up those failures, they adopt a stance where they say, we are not really interested in giving up. So I think assisting such individuals goes a very long way.
Yeah. Thank you. Apart from the association of tobacco with oral cavity and the respiratory system is probably very well understood. I would like to ask Dr. Dilip Kumar with us. He's a cardiologist, and I would like to ask him, is he there on the panel? I can't see him on the panel.
Time.
Sorry?
Dr. Dilip has not joined, sir.
Oh, okay. So I yes, Dr. Chawla, you can take his question that its affection, the tobacco's affection with the respiratory system is understood, very well understood. But what is the association with the cardiovascular system or the rest of the body? How does tobacco cause a problem in other systems? Sir, you have to unmute yourself.
Right.
Yeah.
Being a pulmonologist, it is fortunate that when patient comes, it's a routine part in asking the patient when he sits with you, do you smoke? Do you drink? The first question when he says, because he has a cough. So you want to start when your history is taken, it's a part mandatory to ask, do you smoke? And still those who are smokers still have a feel of guilt. Those who are young, they try to conceal it from their parents. And those who are old and are coming with the disease, now they are regretting, they know they have to leave it, there is no option. And you don't have to do anything. In the beginning, I must thank for the introduction, Dr. Deshpande. Thank you, Dr. Pawan Gupta, for inviting on behalf of Indian Chest Society. I think it's a wonderful activity of tobacco cessation by ICanCaRe Foundation. So to continue with this, when the patient develops a disease, especially of the lung or of the heart, if he has a coronary artery disease, which is directly related with smoking, atherosclerosis of the vessels directly related with smoking, there is no part of the body where vessels are there and smoking does not affect. But primarily, majorly, it will lead to COPD, it will lead to precipitation of asthma attacks, it will lead to chronic bronchitis, it will lead to emphysema, coronary artery disease, heart attacks, CVAs, brain attacks, you can say, peripheral artery thrombosis, what you call is as a DVT, the vascular thrombosis of the peripheries. Then patient can have more important is the lung cancer apart from the oral cancer. The moment he gets a talk and suspicion of some opacity in the lung, now he begs for his life. Forget about tobacco. Forget about anything. You don't have to do anything to ask him to stop smoking. He begs for the life. Doctor Sahab, ab to chhod diya, ab to theek kar do. When he comes with excessive cough, smoking, the COPD, breathlessness, he said, Doctor Sahab, 1 mahina pehle chhod di. Eve to theek kar do. Are this guna which has been done, you have to be very, very clear to him. I was listening to them, single smoke, single cigarette creates so much of damage and you are smoking for last years. So we tell very clearly to the patient, if you murder once, the saza is the phansi. You smoke once or for the life, you cannot be repeatedly hanged. You have to stop it. Wo to chhod di doctor sahab, ab theek kar do bas. You understand? So you don't have to. But this activity of smoking cessation is a wonderful initiative, and you help the patient to stop smoking. He gives a history. We tell them very clearly the burning edge of the cigarette is at 924 degrees centigrade. The butt which he is holding is around 28 degrees Fahrenheit. 7.5 minutes the average cigarette will finish. So his life of 7.5 minutes is gone. So you tell him very clearly, keep smoking, and you are putting your life in smoke for 7.5 minutes with every cigarette. 7,000 plus chemicals are burning at a degree of 920 degree Fahrenheit. Imagine how much damage it will do to the lungs. It's a chronic damage. I tell them, if you start putting your finger on a stone every day at the same point, after 20 years, you will get a spot on that stone. Similarly, the cigarette damages your lungs. Don't expect in one day you are going to have lung cancer. You will have it, don't worry. It is well established by science. The single most important cause for lung diseases is a cigarette smoke. So, and if they are starting cigarette, it will lead to goblet cell hyperplasia, excessive amount of mucus, smokers cough. You have to tell him if it's an excessive mucus, again, they are the nidus for infections. So these are the changes which happen to the lung, to the body system. There is no system of body which cannot be affected by.
Right. Yeah. Yeah. So we have covered the cardiovascular, the respiratory system, and then we go to cancer, where Sir mentioned briefly cancers and something that human species is absolutely scared of. And the teratogenic effect of tobacco is known, and tobacco products are being criticized. Sir, I would like to ask Dr. Jayesh Patel, sir, that he is an oncosurgeon, and when a person with cancer, which you feel has been probably precipitated because of the chronic smoking that the person has been doing, what exactly do you tell him? Do you have to tell him anything, or he's willing to quit, or does instilling more fear, does it help? What is your experience? Sir, please unmute yourself, sir. Yeah, thank you. Yeah.
So when somebody is diagnosed of cancer and they come to our clinic, now I don't think it is good to talk about what he has done in his life. Done is done. Yeah. So as a treating doctor, I would address that you should stop smoking. But by that time, he's convinced, whatever he has done, and he is suffering for the same cause. So what we like to do is we try to concentrate more on our clinical treatment of the patient, but at the same time, we highlight that, if you have not done this, probably you would have been little safe. That is a time we should not be talking about de-addiction, stopping tobacco. So firstly, we do our job of treating the cancer, and then as soon as we finish our job and they recovered, at the same time, we will involve our psychiatric colleague. He would be coming in the picture, and thus parallelly, he would try to de-addict the patient. Now, as we are aware that in India, it is 40% of the load of cancer is mainly because of tobacco and alcohol. If you are in Western India, like if you are in Maharashtra, Gujarat, or Rajasthan, it is almost 52 to 55% of the cancer. They are predominantly because of the tobacco, and people are aware, But it is compelling nicotine which would push them to consume, and to consume. I think as a group of doctors, including all subspecialty and specialty, as I told before, that we should be convinced that we have to spare 5% of our time for preventive medicine. But for me,
sir, related to this, I would like to ask a small question. Many a times, yes, people question our wisdom of giving nicotine replacement therapy. Okay, and they say that it's from the frying pan to the fire. You are giving nicotine. Why is it called therapy? Why should it be called treatment? Pertaining to cancerogenicity. So, what is your answer?
Sir. The question is like, somebody is addicted to some medicine, like a surgeon is addicted to do surgery. When I suffered COVID, I was off the job for 15 days, but from internally, I was so compelled to start my surgical practice. So it is like nicotine is so addictive that, guys, when you say that on one hand you are refusing nicotine, on the other hand, then I have to explaining about withdrawal symptoms, not only psychological, but social as well as physiological. Say in Rajasthan, they allow afim to be consumed on a license base. I have operated many patients, but believe me, my psychiatrist friend would not allow them to get withdrawal of that. So they would continue less dose of afim for particular days and duration, and then gradually they'll be weaning off. So, that takes little time to explain the patient. And I know in today's India, we all doctors are so busy because the volume of the patient is huge. Number of doctors are less, but still, I think I would request everybody of us to spare a little more time to these poor guys who are sufferers of addiction.
Yeah, really. If all of us do those two movements for the patient,
yes,
that would make a lot of difference.
So and believe me, we are role model, sir. The people now, they believe that, yes, doctors are professional, but still, few of them, they believe that we are God. So let us act as a God.
Yes. So I think from strokes to cancers to oral mucosa problems, you have covered a lot. And as sir said that loha garam hota hai, tabhi usko bol do. Okay. Yes. Immediately after the therapy, cancer therapy or stroke or whatever serious disease that he has had. I would like to again ask Dr. Deepak Raheja. Well, we all know as de-addiction expert, people who practice de-addiction, that stopping is easy, but staying stopped is difficult. Okay, so why is it so difficult to stay stopped when it comes to nicotine? Because you said that it is one of the highest difficult to quit substances in the world. So why is it so difficult to quit nicotine when it compares to synthetic drugs or alcohol? Any idea? Hello?
Unmute.
Yeah,
Yes.
yeah.
Am I audible?
Yes, yes.
Sir, so like we've been saying, nicotine is a lot more addictive and difficult to leave than many other drugs. A, because it is easily available. B, it can be consumed in a fairly unassuming setting. C, it crosses the blood-brain barrier very, very rapidly, virtually in about 7 to 8 seconds after the first inhale, first puff. It crosses the blood-brain barrier, begins to create a surge of dopamine, and then subsequently also a minuscule surge of adrenaline, which gives you the feel-good factor. And because it is, I mean, we've spoken a lot about the behavioral aspect, the habituating aspects of nicotine dependence, it starts getting woven as a way of life. I mean, you can just step out, have a cigarette pack in your pocket, or just go to the next door shop or the panwala, pick up a cigarette and start smoking. So I mean, it's as akin to, if I was to draw the commonest analogy, the thing that would come to my mind is the cup of coffee or the cup of tea, which is so readily available. It's within our household, and so we tend to keep consuming it. And like Dr. Rakesh Chawla and my other predecessor was saying, along with, let's say, 7,500 or even more addictive chemicals that go in, at least 40 have been identified to be carcinogenic. And here we have the culprit called nicotine, which is very, very addictive, extremely habit forming, and gets woven becomes a friend who you find yourself inseparable from. And asking to leave your beloved, asking to divorce your beloved with whom you've spent 5 years, 10 years, 20 years is really difficult. And research has also, statistics have also shown that people who stay put are people who started early, don't have enough reason. And like somebody said, maybe just the right counsel. I mean, the reasons have to come from within. The reasons have to come from the person who's wanting to quit. And which is why I think the most successful therapy in quitting, in smoking cessation, is motivational enhancement therapy, because it's non-confrontational, it is respectful, it evokes respect from the person, and helps to it helps to meander the path of his thinking to find the reasons from the subject, from the person himself, as to why he wants to quit. So I think it's very important for us to keep in mind that we should not be judgmental. I was reading, somebody said, even WHO says that it takes a few non-successful attempts before the person quits. So with each non-successful attempt, there should not be an attitude of judgment. There should still be unconditional respect and empathy towards the client, and helping him to resurrect and solidify the mechanisms as to why he wants to quit and keep up being on the wagon and the recovery process.
Right. It is said that it takes 7 falls to make a rider, and it applies to even nicotine quitting also.
Yes.
And as you rightly said, that there are multiple drugs who cross the blood-brain barrier very fast, and they cause havoc in the brain along with nicotine. But what singular factor that probably differentiate nicotine from the rest of the synthetic drugs or all the other drugs is the social permissiveness that is there. And I think information technology is the way by which we can probably reach out to masses and change the opinion about these psychoactive substances. And there we have an information technology expert. Welcome, Rushabh. The question to you is, how does technology help in initial stages of pushing the thought of quitting? Do you believe that IT can help in making a public opinion against smoking? Do you believe that?
Yes, definitely. Technology, as we know it, once leveraged, can reach out to the very farthest corner and within no time. So definitely, technology plays a major and great role in helping us in motivating also the people who are taking tobacco as well as people who are not taking tobacco to motivate others so that their near and dear ones can proceed towards tobacco cessation. So for this, we came up with the ICanCaRe application.
Can you tell us something more about your application?
So in this, the idea behind this application, developing this application was to empower each and every individual so that they have a readily accessible tool where they can assess themselves about their addiction level, they can assess their willpower, they can assess their signs and symptoms that they are facing, and also keep a record over a period of time. They can do their self-assessment on a monthly basis or a weekly basis, and they can record them. Whenever they find that there is a deterioration in their health over a period of time, they can quickly, through the application as well, seek assistance from a network of tobacco cessation specialists as well as multi-specialty doctors available on the application, where they can get the right treatment plan from the specialist. Also with this, as we have been talking about, that there has people who have tried to quit tobacco, they have this fear of failure again. So for this, again, we have put some motivational videos as well on the application, where they can see that yes, it is possible to quit tobacco, and it is a journey that they can take, and with minimum what we can say परेशानी जो हम बोलते हैं, अगर हिंदी में बोले तो minimum परेशानी के साथ वो इस सफर को तय कर सकते हैं और आसानी से with very ease they can quit tobacco.
Yeah, thank you for helping physicians to help their patients. We need more of technologists in our field. Everybody has been quoting Mark Twain, so let me quote Oscar Wilde. He said that I can resist anything and everything except temptation. And craving is something which really triggers the relapse. Let me come to the dentist again, Dr. Garima. When you have so much pathology in the oral cavity, do the nicotine replacement therapies work or they don't? The other thing is that, I just said that, putting them from fire to the frying pan, we know that the tobacco has more cancerogenic system. So remove tobacco, add just nicotine, and it's a safer drug to take to control the craving. So your views on nicotine replacement therapy, your experience, and in cases of pathology, do you think that the absorption is hampered?
Yeah, I think nicotine replacement therapy, it definitely works well, especially because it reduces the craving. It's convenient to use. It does not stain teeth, which I like as a dentist. And it's also very cost effective. There are a lot of options like gums, lozenges, sprays, patches. We can also use a combination therapy in the nicotine replacement therapy. In terms of gums, I've seen that we need to be a little bit cautious when we use in patients with temporomandibular joint disorders. Also, I've seen that lozenges have worked better than gums because the absorption is more of nicotine as compared to the gums. And also some of my patients have said that the taste is better as compared to the gum. And it's well taken. They can also use patches. We have 24-hour patches in Australia that works quite well. Some patients I've seen that they use a combination of them, like they'll have a lozenge as well as they will use a patch. We also have the oral sprays, but the other thing to consider is that sometimes it can cause an irritation if we are using a spray, and especially if there, as you said, if there is already a pathology, a mucosal lesion that can cause more of an irritation with the spray. But I think it's a wonderful tool in smoking cessation because it's got its own benefits, and I think the patients can use it in their own pace. And if they don't like one of the options, then they also do have the other ones.
Yeah. Dr. Chawla, any experience with nicotine patches, nicotine nasal sprays? Have you used them in your practice, Dr. Chawla? Sir, can you hear us? Okay, Dr. Patel, you can take that question.
Yeah, at our regional cancer center, we use it a lot. But, as Madam said, the cost in India is little constrained. Secondly, consistency, to get the patch is not that easy for the peripheral centers. At regional cancer center, we can easily get all those patches and replacement. But, 80% of the India is in remote, in urban, rural area. So there it becomes a problem. And secondly, commitment of the patient is very poor. Say once the patient comes to us, I don't think I've seen any patient trying at the 8th time, So most of them, they either suffer cancer and they just quit like that without any support, because of social pressure. But those who are an active life without any disease because of the tobacco, I think in Ahmedabad, there are 2 rehab centers where, they charge particular amount of money and keep the patient indoor for a month for de-addiction. Now that is, completely non-productive. So I think gradually with the time, I think the attempts like this would improve overall package of the de-addiction program. And probably we might run such programs like Western world. And that is the time we are expecting very fast, We have to do that. Yeah.
Right. Yes, Dr. Deepak, any anti-craving substances that you use, your experience with Bupropion and Varenicline?
So quickly drawing a parallel, I do think the NRT works very well. I do not think it is substituting, just merely substituting one nicotine to another. It is actually doing away with a lot of combustible carcinogens that come with the combustion smoke of the cigarette that is inhaled. And of course, the idea is to start the patient on supportive work, preparing them for abstinence, so that it is a mechanism where the nicotine is only used as a replacement to be weaned off. Now, coming to Bupropion and Varenicline, so, one of the key chromosome that has been studied vis-a-vis the addictive process and the process of quitting is the chromosome 15. And various arms and various sites of chromosome 15 have been studied. And there have been actually some interesting studies to show which are the kind of samples who respond more to Bupropion and which are the samples who respond more to Varenicline. But both are good options in terms of deciding a quit date, but I still do feel, a lot of patients with whom I've used Varenicline have come back to say they feel it's like a magical drug, I also feel apart from what the drug really does, there is a significant psychological support, the placebo component that comes with the whole process of recovery. The patient knows that there is help available. He's talking to a clinician. There is, whether he's talking to an internal medicine guy or a pulmonologist or a psychiatrist or a counselor, we're all doing counseling in our own capacity, and that's a huge support to the patient. So I think the moment patient knows he's into a program, he's being spoken to sensitively with empathy. And then I think if we've spoken a lot about the multimodal approach, it would necessitate that we do not discount the importance of some of these pharmacotherapies, which have been well studied and have tested across various double-blind control studies to show efficacy. So, I think these are both NRT, Bupropion, Varenicline, and other stress-relieving, stress-removing pharmacotherapies, along with psychosocial, non-pharmacological interventions woven into a program. They help bolster the confidence and the motivation of the patient to quit and to stay quit. The whole idea being that it's easy for them to get a quit date, to give up. And then, I think the repeated failures happen because the thought that one won't hurt I can just do one. So you just have to start preparing the patient for that. It will never be that one puff. It will never be that one cigarette.
Right,
if you slip up, it'll be the process all over again. And I think with that support, we sometimes use a lot of relapse prevention strategies. We use a lot of cognitive behavior therapies. And I found that utilizing some of the principles of 12 steps, whether it's used for Alcoholic Anonymous or Narcotic Anonymous, but that one day at a time. I will not do it today. I'm having the craving right now. I will reconsider my craving after an hour. And we found that the cravings of tobacco, they're very intense, but they are very short lasting. So if you can do away with those few moments, the next thought is going to be different. They can go into a shower. They can go for a small jog, a run, a physical exercise, a massage, a hot water shower. And I think with these multimodal approach and mechanism, the results are pretty gratifying.
Right. Right. In de-addiction medicine, it's a rule that says that every dollar spent on prevention earns you more interest than every dollar spent on treatment. And that is the reason why any effort at treatment has to have accompanying effort at prevention. And as I said in the beginning of the program, when people make a choice of smoking, at that time, they should have sufficient information. And for that, a huge amount of social engineering is required. And again, for that, through social engineering, we look at the technocrats, Rishabh and your colleagues in the industry who would be able to understand the gravity of the situation, the kind of money losses that we have because of the tobacco use disorder. For the want of time, I would probably miss the question and come back to the last question. Dr. Patel, we want your wisdom, your understanding of the situation about what is the role of tobacco cessation clinics for general physicians, family physicians, any pathis that are there. What do you think is the role of tobacco cessation clinics? How will these people benefit if they have a tobacco cessation clinic under their roof?
I think, sir, this is a need of time, and I might suggest that that we should have a small course in undergrads of MBBS as well as in dental surgeries. And you rightly said all pathis, because the future is so close that there'll be a mix of pathis, and it is essential probably. So one, that my suggestion would be that we should have some sort 1 month or 2 month program, undergraduates. We should start cessation center in all medical school, essentially by NMC. They should make an essential remark that all the hospital or all medical colleges must have a de-addiction center or cessation center, because a $1 spent for prevention probably would save $1,000 for treatment. Third important things, as a doctor, we work in isolation. I would request everybody of us that we should have collaborative lateral collaterals. Like, regionally, what I do is I would contact Chamber of Commerce, I would contact FICCI, I would contact partners of industry, I would contact school and colleges. I go there and talk about tobacco, alcohol, de-addiction, cessation. So I think, and once you add this feather in your cap as even family physician, this is a need of society. So by getting educated about de-addiction, probably you would not only serve the society, but commercially you would make good amount of money also. So this looks a future direction towards cessation, and that requires commitment of all of us, as a medical fraternity. So I think you are the best judge, and you can conclude that God give us wisdom to take this task as our essential work,
Yeah, sir. It is said that don't poke your dirty nose into people's business. But here, I think we have to poke our nose in other people's dirty businesses.
Yes, sir.
So with that, I would like to end this panel. Thank you very much for being very patient, and my apologies for the curtailed time. I would now request Dr. Sandeep Kadam and Dr. Harshad Thakur to give us their comments. Thank you so much.
Thank you, sir.
I think Dr. Harshad can take up.
Okay, thank you, sir. So I thank Dr. Pawan Gupta for inviting me in this ICanCaRe series of webinars. And I think this was quite a good, wonderful panel discussion. So we have presence of doctors from various fields, dentist, cardiologist, pulmonologist, oncosurgeons, and even IT specialist, and a psychiatrist, of course. So we had a very good discussion, and I think majority of the points are discussed. One or two points which I will like to add is, one is we are all of us are specialists. So we are dealing with patients when they are coming to us at specialist level. So we have to see that when patients in early stages, when they visit primary care physicians or initial phase healthcare workers, that time also they should be able to create awareness. Means we don't need to wait so long that after having cancer or major disease, they should be convinced about stopping the nicotine or tobacco. And second thing is technology. Yes, it is playing a role in reducing tobacco, but also simultaneously technology is a double-sided sword. So technology, we can see, is also promoting tobacco and tobacco-related products. So actually it is up to users how to use this technology. So technology like which Mr. Rishabh Agarwal ICanCaRe is using, they should see that this technology is more prominent and dominant as compared to other technology which is promoting these addictive products. So thanks again, and for final comments, I invite Dr. Kadam sir.
Thank you, sir. Friends, it was a learning seminar for all of us. Even we have learned so many things during last 2.5 hours. First of all, I would like to compliment and congratulate Dr. Pawan Gupta and Dr. Desai for organizing this series of webinars for all of us. My compliments and my best wishes for them for future their endeavors. Friends, I am being a pediatrician, and also I am representing Rotary International District 3142. And I'm very happy to inform all of you that during last year, last 365 days, we were working very hard, and we have undertaken pilot launching of program related to de-addiction. And I'm very happy to inform you that Dr. Ashish Deshpande was our scientific advisor, who was involved in last 2 years in planning this program as a ideator, as an advisor, and even we have interacted with so many of you. Dr. Harshad Thakur and many other faculty members were also a faculty for those programs. In that de-addiction program, we felt that creating awareness in the community and sensitizing the community is the basic start. As someone has rightly said, prevention is better than cure. Why can't we target school children, college going students, adolescents, because they are the more vulnerable for this group. If they are aware what are the side effects of these kind of addiction, I am sure during their young age or reproductive age, they will be staying away from these addictive substances. As we all know that this is not a one-man job. It requires a multi-pronged approach. And I was very happy to see that you have involved almost all types of multi-specialities while dealing with the subject. I also would like to suggest that, and I also would like to compliment for also involving so many organizations who have joined hands with you, like even Rotary Action Group, Addiction Prevention of India, as well as international body. If we can really join with these NGOs, they have volunteers. Like We have in India almost 1.5 lakhs Rotarian who have committed, who have pledged to be a Nobel volunteer to serve the society. And they will be helping all of us in taking this project forward. So if multiple organization comes together, then I think we can really take this project for a long period. Another suggestion which I felt that we were attending about 160 participants. How many of us are smoking? That is a question. Or how many of us are using the tobacco products in whichever format? If at all few of us are using, we should be the first one to initiate the tobacco cessation, and then only we can lead from the front. That was another suggestion. Whenever we are attending OPDs, there we can have a video session for creating awareness and sensitization for the masses, where we can put those deadly pictures of having cancerous lesions and operated patients, so that they can really get a threat of it. The patients who are addicted, if they can really see what are the side effects, what are the endpoints of these addiction, they will be taking those steps to withdraw from it. And I think entire speakers who spoke from their heart, and they were passionate about doing works under this avenue. The Tobacco Cessation Clinic is also another good idea which has come up, and adding curriculum in the MBBS degree is also important suggestion which sir has suggested. I think if you all join hands together to see that the growing menace of tobacco use in India and all over the world can really be reduced with the efforts of each one of us. Thank you very much, and I thank organizers for inviting me to this seminar. Thank you.
Thank you so much, sir. It was really wonderful, and thanks to all the chairperson for the panel, moderator, Dr. Ashish, and all the panelists for the wonderful presentation that we had, and a lot of discussion and a lot of things that have come up. Of course, the next, on the 25th, we are going to have a wonderful session where we will sum up and come up with some consensus, how we can actually, like what Dr. Sandeep Kadam has said, how we can actually involve everyone and take it forward. So with this, I go to our next program, and that is a very interesting program, and that is on the quiz. And the quiz master, I'll just like to invite the quiz master. Yeah, Dr. Adita, she's here, Dr. Adita, as the quiz master. Yeah, hi, Dr. Adita. So just introducing Dr. Adita. Dr. Adita is a psychiatrist, and she has got more than 10 years of experience, and she has been working at the NaviCare clinic at Andheri. So she has got, of course, has got a lot of experience in various de-addiction program as well as for tobacco. So without wasting much of time, we will just get into the quiz. I think Adita, you would be sharing the slides, or
so if you can share the slides.
Okay. So Adita, you can announce the rules are that the fastest and the highest gets the prize, and all the three quizzes that we had in the 3 days, the day 1, day 2, and day 3, it will be all added together to come to the conclusion who is the winner. and we will be the chat box will be completely muted, and the chat box will be disabled and it will be muted so that people cannot talk to each other or give out the answers. And we will share one of the links, and that is the Google page link where we have to start the quiz. So this is how it is going to happen. And before you get the link, I would ask you all to please join the Facebook page, which is I'm just putting the link of the Facebook page. This Facebook page will have all the details of the quiz and other details that we are having. Yeah, here is the Facebook page. So please, I would request those who have joined earlier, it's thanks to them, but those who have not joined yet, please join the Facebook page. It will just take 30 seconds. Just click on the link and join the Facebook page. And here Rishabh will be putting the link to the quiz Google page, and then we will take it forward. All set, Dr. Aditya?
Yes, sir.
Rishabh, you want me to share the quiz or you are sharing?
So if you can share, then it will be good.
Okay, I'll just share. Can you put the link? Just give me a minute.
Quiz link is on the chat box.
Okay, the quiz link is on the chat box. Please fill up the first few questions, which asks you for the details. By this polling question. Okay. So can I ask, is everyone set to go for the quiz? So we would like to thank our supporters, that is the Triscare, the Tobacco Nil, and the No Smoke, for providing the support that we required for the program. And of course, this is the community page, and we have already had the instructions. Please fill up all this email, mobile name, institute, city, and occupation. And I think we are ready for the quiz. All over to you, Dr. Aditya.
Yeah, thank you so much, sir, and all the best to everyone for the quiz. So I would like to start the quiz with first question, which is that which one of the following is likely to be the most effective at helping smokers quit? The first option is group behavior therapy, self-help materials, opioid antagonists such as naltrexone, or quitline. So we move on to question number 2. Which of the following best reflects the evidence on smoking cessation interventions to increase the chances of quitting? First is there is good evidence that acupuncture is more effective than control. Second, there is good evidence that hypnotherapy increases rate of abstinence at 6 months more than no treatment. Third is, although physicians commonly advise their patients to quit, there is no good evidence that such advice increases the odds of quitting. And the last is, although training health professionals to ask patients about smoking and to offer them treatment leads to an increase in number of smokers offered advice and support, there is no evidence that such training leads to more people quitting. Third question, which one of the following is a risk factor for smoking in adolescence? First, higher socioeconomic status. Second, participation in extracurricular activities, including sports. Third is emotional closeness to parents. And fourth is physical or sexual abuse. Question number 4. Roughly, what is the percentage of attempts to quit smoking without assistance that are successful? 1% to 10%, 30 to 40%, 60 to 70%, or 90 to 100%. Number 5, which one of the following statements best reflects the evidence on different forms and doses of NRT for treating nicotine addiction? First, there is good evidence that therapy provided in the form of gum is superior to therapy in form of nasal spray or an inhaler at achieving abstinence. Second, there is good evidence that oral therapy is superior to patches at achieving abstinence. And third, in highly dependent smokers, there is good evidence that a 4 milligram dose of gum is more effective than 2 milligram dose in achieving abstinence. Number 6, no cheating on first day of NRT increases your chance of quitting smoking by factor of 3, 5, 10, or 20. Number 7, ABCD of tobacco cessation includes all except A, behavior changes, B, active motivation, C, comorbidity management, and D, diet restrictions. Number 8, which of the following is accurate about NRT? Transdermal nicotine patches are associated with lower compliance rates and higher side effects than NRT designed for acute dosing. B, nicotine gum is the NRT capable of delivering nicotine the most rapidly. C, the amount of nicotine absorbed per nicotine lozenge is somewhat lower than that absorbed from nicotine gum. And D, NRT use increases the quit rate by 50 to 70% and increase appears independent of any additional support provided. Number 9, when is the World No Tobacco Day? June 1, November 23, May 31st, or November 7th? Number 10, what is the full form of SHS? There is a hint here that if father smokes, other members of a family are prone to. Number A, short, higher smoking. Number B, second-hand smoke. Number C, second harmful smoke. And number D is second hated smoke. Question number 11. Which company introduced the first nicotine transdermal patches in India for NRT? First, Tobacconil by Rusan Pharma. Second, Nicotex by Cipla. Third, Nixit. And fourth is Nicoderm. Number 12. The only country in the world which has banned tobacco use in the country. A, Republic of Malta. B, Vatican City. C, Bhutan, and D, Republic of San Marino. Number 13, who introduced tobacco for the first time in India in 17th to 18th century? Portuguese merchant, British East India Company, Alexander III, or native Indians? Number 14, which of the statement is true about cigarette butts? Butts never break down completely. B, butts cause toxic effects on environment. C, butts are the most common item littered on the roadways and beaches. D, all of the above, or E, none of the above. Number 15, what percentage of male doctors smoke as per WHO stats? 50%, 40%, 60%, or 30%? Number 16, the famous quote, "Smoking is easy to quit. I have quit hundreds of times," was by Albert Einstein, King George I, Shakespeare, or Mark Twain. Number 17, The only company popularized tobacco cessation in India extensively is WHO, UNDP, ICanCaRe, or WeCare. Number 18, submucosal fibrosis is caused by areca nut, nicotine, slime lime, or pan leaf. Number 19, most addictive substance in the world is heroin, cocaine, nicotine, or alcohol. Number 20, for tobacco cessation, the 360 intervention includes behavior therapy, pharmacotherapy, comorbidity management, oral screening, relapse management, or all of the above. So this is a compulsory. Would you practice tobacco intervention in your routine after this workshop? It's either yes, no, I want to start a ICanCaRe Tobacco Wellness and Oral Screening Center, or I want to get trained in tobacco intervention. This is a compulsory question to answer. Thank you so much.
Thanks, Dr. Adita. And I think it must have been a lot of exciting questions that you have set, and a lot of participants must be quite excited to answer the questions. So,
thank you for giving me the opportunity to be the quiz master for the day.
So any questions from the participants or anything that they want to say, you are most welcome. Please raise your hands and we will call you to the forum. Yeah, Johnson Pradeep, he has raised his hands. Sir, please unmute yourself and please.
Thank you, sir. Sir, I think the program is fantastic, and I think you have brought all the faculty doing some kind of work in smoking cessation. Not only that, you have brought experts, you have brought politicians, you have brought the IPS tasks masters. No, I think everybody have brought an hats off to your work, and it is really a wonderful session. I think you should form some kind of network so that we all are together. We can all, like as Dr. Professor Nimesh Desai had said, to form some kind of a consensus document. And the outcome of this international conclave should be that we should come up with some kind of a consensus document so that we can set an example for all the people. And there are a lot of various suggestions, like, for example, introducing a curriculum in the undergraduate medical program. So like that, a lot of suggestions have come up. I think we should condense everything together and submit it to government. And I think you should take that lead, sir. I think you have put in your heart and soul into this program. I think hats off to you, and I wish you all the best. I hope this will be a very fruitful session, and in the future we should be a role model for other countries where tobacco related deaths or mortality should come down. Thank you very much, sir.
Thanks, Dr. Pradeep. I am sure Dr. Nimesh is here, and the next program is basically on that the next Sunday. It is on the consensus guidelines that we want to make, so that, because tobacco cessation is a complex disease and everyone is working on it in their own way. So this actually will create a difference in the society, and that's what we are working. And Dr. Nimesh is actually had to leave at around 6:30, but of course this is what we will take forward. Thanks for the suggestion, and definitely this is what we are going to do. Saurabh Singh wants to say something. So Saurabh, I think he has raised his hand and he's disconnected. So I think we will come to the end of the program today, and over to Dr. Reena for the.
Thank you, Dr. Pavan. And thank you to everybody here, who's made this amazing program really super, because the amount of interactions and the amount of learnings, and from worldwide, because today we have a perspective, not just from India, it's from the global perspective of people working in different areas and exactly what they are, all the way from Australia to United Kingdoms, we have that. And it's really interesting to note that all of us are in it, and we all believe that there has to be a balanced approach. And this approach has to have, a assured feeling with a lot of assurance given to the patients, non-judgmental doctors, trained, capacity building, visibility and availability of our specialists to be available. And most importantly, what really came out is how we all need to work together. So interdisciplinary, not just intra, and each one of us learning that there is something which our patients require, which needs the other person to be helping the patient out, because that is when we are able to reduce the comorbidities. And of course, the digital, the digital touch and that particular high point is which is actually going to make the difference and transform things into a much reachable, scalable, accessible, and making it for all. I'm quite certain that next week is going to be highly exciting, because all of us and our moderators and chairpersons have been working very hard and creating the learnings from each session and bringing it in. And next week, we're all going to brainstorm together, and we're going to have, lots of people coming in. And I'm quite sure at the end of this 1 month, we'll have definitely certain, consensus on how do we go about, because definitely we require there's a physical aspect as well from the biopsychosocial, and from all our thinkings that we know that there's a biopsychosocial, there is a biologic, there is an addictive aspect, social and a psychological aspect. And most importantly, the role of drugs, the role of NLP, weeding out the negative things, bringing in with CBT and every other thing that really works. And of course, the role of the dental surgeon, which plays a huge role, and the teachings which we have to take about examination in the mouth, especially because of the part of the country that we live in, and the part of the world rather that we live in, where there is so many users of chewing tobacco and forms of tobacco, where a simple mouth opening test itself is going to give so much. And we at ICanCaRe have developed so many modalities with, of course, with the backbone that we have of Gujarat University, where we innovate, incubate, and bring out newer modalities to help our patients. Thank you so much for being with us, and have a great Sunday of what remains. And let's see you all next week again. Thank you so much.
Thank you. Thank you, ma'am, and thanks to all the participants. I think we have done for today, and we will close the session. And
before that, can I thank Aditi for the wonderful Quizmaster's job that she did? Thank you for that.
Yeah, Adita.
Thank you so much. Thank you.
Also thank Dr. Nandita.
Nandita was rocking. She rocked throughout. I've been putting it out.
Dr. Nandita, I can't see her. Is she still there?
Yeah, I'm there. I'm there, Dr.
I was looking
Nandita's been rocking the show.
So that I couldn't find you, so I started speaking.
No. Thank you very much, Dr. Pawan. You have the right to speak. I always tell you and Dr. Reena should be speaking first, and of course Dr. Desai as well. And thank you very much for bringing everything together. We should have a rocking session next week, because I have to declare the consensus as well. That's my part at the end. So please, all of you, make it easy for me what we can do. Thank you so much. Thank you very much.
Thanks.
And bye from the UK. Hopefully next week also we have good weather here. Thanks.
Thank you, everyone.
Take very good care. Stay well and stay safe. Thank you.
Bye, everyone. Bye.
Thank you, Dr. Vasanti. Thank you, Dr. Garima.
Thank you, everyone. Thank you. Thank you, Rishabh.
Thank you.
Garima, what is the time there in Australia?
It's 11:37 in the night.
Okay.
Yeah, we are 2:37 in the afternoon.
Yes.
The evening is still young, Garima. Huh? The party has just begun.
Okay.
That's right.
Okay. Have a nice evening, everyone. Thank you.
Thanks, Vasanti.
Thank you.
Thank you, sir. Thank you. Bye-bye.
Okay, bye.
Thanks, Dr. Vasanti. Bye-bye.
Thank you, sir. Thank you, Dr. Pawan. Bye.
Bye-bye.
Thank you, Dr. Reena.
Bye, Vasanti. Great having you here. My pleasure, really. Bye-bye.
Bye.